universitāšu pārvaldības tēmās, ar kurām mēs saskarsimies vistuvākajā laikā, un arī nepieciešamība kaut kādā mērā definēt universitātes strateģisko specializācijas virzienu, ir tas uzdevums, kurā tad mums ir jāparāda un vēl precīzāk jānovieto šis dzīvības zinātņu pētījuma virziens universitātes daudzveidīgo pētījumu spektrā. Un, manuprāt, tā ir ļoti, ļoti būtiska, nozīmīga, varētu teikt, pat centrālā vieta, kurā mēs gan savā studiju, gan pētījumu attīstības plānā varam ieraudzīt šo medicīnas, veselības, cilvēka dzīves kvalitātes visplašākajā nozīmē virzienu Latvijas Universitātes turpmākajā attīstībā. Jo kas gan cits, ja ne šie cilvēka dzīves kvalitātes, cilvēka mūža produktīva gadu tēma, varētu būt Latvijas Universitātes gan studiju, gan pētījumu virzienu uzmanības centrā, īpaši ņemot vērā tieši Latvijas Universitātes unikālo atbildību un unikālo misiju par un būt un strādāt, lai veidotu Latvijas valsts, Latvijas tautas, Latvijas tautsarniecības kultūras attīstības pamatu. Un kas tad ir šis pamats, ja ne vispirms cilvēks, un ja ne cilvēka iespējas visplašākajā veidā, izmantojot visdažādākos zinātnes sasniegumus, īstenot savu potenciālu, savu intelektuālo, savu garīgo, savu emocionālo, savu fizisko potenciālu, strādājot visu šo mērķu sasniegšanai. Un tādējādi visi universitātes pētījumu virzieni, sākot ar humanitāro jomu, valodas, vēstures, kultūras pētījumu, turpinot ar fizikāliem, sociālām zinātnēm, kaut kā kļūst par nepieciešamu daļu un komponentu šo dzīvības, medicīnas, veselības, zinātņu, progresa nodrošināšanu. Un tas, ko mēs redzam šodienas konferencē, ir brīnišķīga iespēja, brīnišķīga sinerģija, kas veidojas starp moderno medicīnu un visplašāko spektru citu moderno zinātņu attīstībā. Te mēs redzam medicīnas un datu zinātnes, te mēs redzam medicīnas un materiālu un mehānikas, robotikas, miedarbības. Te mēs redzam medicīnas un ķīmijas, radioķīmijas, miedarbības iespējas. Un noteikti tajās visās ir gan sociālai, gan tiesiskie, gan, protams, arī kultūras aspekti. Un tas ir šis universitātes, universālais kods, kurš modernajā precīzijas medicīnā īstenojās savā pilnīgā izpausmē. Un vēl, protams, man ir liels prieks, ka mēs neesam vieni šajā attīstībā, ka mēs šajā attīstībā esam kopā gan ar mūsu lielajām klīnikām, kas ir mūsu arī bāzes vietas praktiskā virziena īstenošanā, studiju, klīniskās daļas īstenošanā, gan arī neatņemam un ārkārtīgi būtiska vieta pētījumu norisē. Un esam kopā arī ar mūsu starptautiskiem draugiem, partneriem, atbalstītājiem, dombiedriem, potenciāliem projektu turpmāk veidotājiem, ar doktoru Garškeviču no Tallinas Ziemeļu hospitāla, kurš ir arī Igaunijas, varētu teikt, vadošais radiologs, jaunu ceļu gājējs radioloģijas attīstībā, ar profesoru Adalī, kurš noteikti mums parādīs jaunas iespējas ķirurģijas metožu attīstībā. Un tāpēc noslēgumā burtiski dažs vārds angliski. So I'm extending my welcome also to Professor Adali, to Professor Gershkovich. Professor Gershkovich is present online, but nevertheless, welcome to this meeting. We hope that this meeting will create numerous new ideas, incentives for the development of medical studies, for the development of research in life science at the University of Latvia, because we all believe, at least it's my sincere belief, that health science, the care about human well-being, care about the possibilities of our people to have more and more productive and qualitative years of life. This is the core interest of the university and part and parcel of fulfillment of our university's mission. And I'm really glad that this very interesting and nice conference is some sort of event which finalizes the week of the university's anniversary, which we all celebrated this year, and this was 102nd anniversary of the University of Latvia. So, we would Kreskat Laureate, and all the best for your meeting. Thank you very much.
Liels paldies rektora kungam un gribu aicināt profesoru Ergli ar lekciju par precīzijas medicīnu.
Labrīt, cienījamies rektora kungs, labrīt, dekāna kungs, labrīt visi viesi un dārgie kolēģi galvenokārt. Es tagad drusku mani sajūtas, kādā valodā ir jārunā tā lekcija. Nav atbildi? Angliski, okay, so, and then that's a bit confused because the sectors gave this speech in Latvian, and that's why, but it's of course the University of Latvia, and what I want to say is that it's, I guess, very connecting with precision medicine. If you look here, I like very much this one word and one health. Of course, it's not so easy because now we know that so many experiments and other things we are doing in space. That means that the world is too small for, let's say, maybe from James Bond, but of course the world is too small to go for real medicine. And for this reason we are going for, could you give my slides or how I can get them? And this is a really, I mean, for the future. The other thing which is important, it's really important, and I'm very happy that this conference named like scientific and practical. And I guess it is so important, science and practice. And if you look on medicine, it is this is, you know, we are the best example of technology transfer, because usually if we have something new, it goes directly to practice. And of course, on the other hand, medicine is quite conservative. That's why we are having, if you look on our infectologists, I'm really sorry I'm a bit late because we had big discussion what we can do in hospital during and then now in the meantime when we are having so I mean incessive COVID patients and of course all us with other comorbidities, then we actually changing our guidelines practically every day. Even sometimes in mid of the day we are having different I mean evidence. This is my disclosure slide. I don't know if it's necessary or not, but I'm always using this. And if we look on healthcare during centuries, of course, it is we can start from Chinese medicine 4,500 years ago. But if you look on maybe what we are knowing better now, then you see that in the 19th century, actually it's before father of X-ray, Wilhelm Conrad Röntgen, who showed us and who introduced world with a completely new idea of X-ray and how we can use this in medicine. We mostly look on extensive patient observation, of careful history taking, of course of skillful, very skillful physical examination, use of clinical blick. I don't know it's right in my this German pronunciation is not so good, but I guess it's understandable. And if you look here, we still have doctors who are really talking, and we should talk. And this is also a very important problem. How we talk with patients, with relatives of patients, and so on. And of course, this was like what we call now analogous way of thinking. And then it's changed a lot. Actually, it is one of the biggest steps in last, I guess, we will see, but 150 years, even maybe in 200 years, the world first human X-ray. And here you can see Wilhelm Röntgen. You can ask why his spouse. And I tell you one thing which is quite strange, because the first Röntgen picture was done by her hand. He bit afraid to put his hand in there. He asked his wife to put the hand under this X-ray, and that's how what we see. And now she is in history, and I guess in nowadays it would be a big scandal, looks like, but at that time it was a bit different. So, and then the next, I will talk, of course, precision medicine, but I'm a cardiologist, and then you can imagine that I maybe know, and I more closely can speak with, speak about cardiology, and then you'll see how again to change at that time the first practical electrocardiography and the electrocardiogram. And actually this only looks like that it is so simple, and we know that today we do this every day. We can even in our we can see our heart rate and some complexes in our watches. We know this in our phones. But at that time it was breakthrough. It was a real revolution, and that's why it is quite interesting. In every step we can talk about precision medicine from different angles, which is quite really, it is quite, I guess, impressive. And you see, and why I'm talking, because he also got this, and Eindhoven, this Dutch engineer, and he made that, and you see where he put his leg and hand, and this machine was really, I mean, completely different if we look from meantime and nowadays machines, but then he get a Nobel Prize in physiology and medicine. And this is interesting. Why I'm talking about those two guys? The one was a physicist, the other was engineer. And if you look also a bit further on, usually Nobel Prizes in medicine not going to medical doctors. And this is the point why rector talk about this university like unit where we are coming together from so different specialties. And this is the way how we should think about future, how we should think about precision medicine, how we should think about quality of life. It's not depends only on medical doctors, it depends on everyone from different specialties, and even we will see later on, it's really depends on our social security, about our thinking, and about actually our politicians, which is maybe sometimes one of the weakest parts of this continuum. And here you see this ECG signs of myocardial infarction, can I show this? There is this arrow, or okay, well, yes, it's over there. You see there's ST elevations, and this is one of the first cardiograms, and as you see, it is published in Archives Internal Medicine in Chicago, 1920. If you look on, for example, I will take only a couple examples, and this is a treatment of myocardial infarction, the past, the present, and the future. Then you see in phase 1, it came, when we actually can talk about that, it's from 1912 to 1916, that it was just a best rest and expectant treatment. The rest relief of pain, anticoagulation was, you know, this was a bit strange, and the coronary vasodilatation. Then it really was actually again the jump, and there was a phase 2, and at that time it was really fashionable and modern, and the segregation of patients with acute MI into specialized intensive care units, and continuous ECG monitoring, and also the training. And this is, but that's because the same thing now, the training of medical and nursing staff in resuscitation. And that's why also we should look on our nurses. And when the people asking me why we need, they're so educated, and actually even scientifically educated nurses, then we can go back 60, 70, 80 years back and to show why and how it can help, and to actually to put the medicine on next level. Then from 1975 and to present, this is a myocardial perfusion. It's intracoronary fibrinolysis versus primary PCI. And now if you look on phase 4, this is a present and future imaging, and now we will coming more close to precision medicine, because actually the precision medicine is genotyping, genotype, and phenotype. And actually, this, if you look on phenotypic, this examinations, it is of course the imaging, high resolution imaging. Now we use more and more this imaging, and this is a regenerative medicine, and we call, this is maybe not very, how to say, because the imaging and regenerative medicine, this is inside the precision medicine, but it's like with this green, how we call this, not economy, but this, okay, doesn't matter, but then sometimes we are changing these definitions, but doesn't matter. If you look back on history of perfusion medicine, there is also quite interesting in different parts of the world, and one of the first was, it's a bit, how to say, and that time it was a really also interesting story, but then it will be too long. It's done by Professor Chazov in Russia, and Lenzop in Germany, and they did actually parallelly that. But interesting that it was published only 15, 16 years after actually the first perfusion. And that time they did intravenously and then intracoronary those perfusions and fibrinolysis. Why it is so important? Here I show you a small example how what we are having and what patients having when they have MIs, and this is the right. Because a pointer or if you look there, then you see there is a thrombi inside. There is actually ruptured plaque, and Professor Isaias knows very well how it looks like inside, and so on. But there's a ruptured plaque on left from the left panel, and there in middle you see the thrombi, which we aspirate from artery, and here you see completely restored flow, and after stenting, and then you see that actually the MI is also practically solved. Okay, this is, and there is the interesting what we can, and in past actually what we did only thrombolysis. If we do thrombolysis, we can restore a flow, but actually we do nothing with this ruptured plaque. With mechanical perfusion, we do all actually restoration of native native vessel walls and real flow to myocardial. And this is again why it is so necessary and why it is so important and why we need to use technologies, why we should learn about that. Because if you look, for example, of early mortality rates in major randomized STEMI trials from 86 to 2008, then you see what's the rate of mortality. And this is if you look here, it is 4-fold decrease the rate of MIs from, and this is I'd say, in very actively treated group. Then you can imagine what was the rate in non-randomized, of MI rate, death rate or early mortality rate on non-randomized studies. This diagram show you very well how, again, with each step from control to pharmacological revascularization, we went to mechanical revascularization, and you see with each step which we introduce, and again in this continuum of precision medicine, we can improve the outcomes. This is also of course, it's not only a question about maybe so acute mortality, because if we have, of course, first of all, we should go for primary prevention. The primary prevention is very important, and then we can decrease the rates of MIs. On the other hand, if someone have MI, she or he, then of course it's very important to do everything actually to decrease the infant size of heart. And this is a question how we can do this and how we can measure this. And if we want to measure in a very, best way or in very, I'd say, valuable way, then we should use or SPECT or MRI. And this is again the question why we need to do research on those two, not 2, 3, 4, 5 methods, again with higher resolution imaging. This is only why I showed that. And for example, on the next slide, this is, you see that we have the non-invasive imaging, these completely new models on sign MRI, of T2 map, on contrast MRI, and so on. And this is again why the director we need to go for here in university and to get those machines, because it's not enough that we have machines like this in somewhere in polyclinics or in other hospitals, because we should do research to improve and to understand the best way how we can use them. It is not only to do one imaging. We should understand the relationship between clinics, between pathophysiology, between physics, between physiology, between biology and other things, how it relates on our health, on our quality of life. No, of course, it is nothing very, very special, and we use that in different. This might be Latvia a bit less, and that's what we need to increase. But if you look on what we use, all those kind of different what we in the past call like toys for invasive cardiologists. Now we do this in daily practice. This is intravascular ultrasound. This is tissue characterization. And this is a functional flow reserve measurements, which is a functional testing of different kind of lesions. This is optical coherence tomography and the different kind of co-registrations and others. But of course, for all those methods behind, we have a science. We have a science and evidence. And we should understand how we introduce this in our daily clinical practice. Again, this is cardiovascular magnetic resonance imaging in cardio-oncology, and I just did it on the same place. I gave a lecture last Saturday, and now it is a new specialty, what we call like oncocardiology or cardio-oncology. because we have so many common patients. If we look on a different kind of after the impact of radiation on heart muscle, impact of radiation of blood vessels, and so on. Also about the thrombotic processes, antithrombotic therapies, and that's why we are also now need, and we have practically the completely different needs. And then, of course, it is also not enough, because if we look on this intersection between cardiac metabolism and cancer biology, that we've seen that there is also the points where we are together, and we need, for example, we need to look on keto metabolism, and this is the same for cancer sometimes, and the myocardial tissue. That's why it is so. For example, if you look on risk factors, and there is a completely the same, and this is the lifestyle and metabolic syndrome, diet, it is smoking, and of course, and that's why as I said, we have so many common things to do and to think about that. For example, this is one of what I like now very much, because now we, in the last 5-6 years, we change our understanding, and I show you in the next slide. But what we see that this ketone body infusion and myocardial blood flow metabolism by positron emission tomography CT. This is what we can see, and how myocardium consume those fats and to get energy. Because if you look on these fuel profiles of the heart and leg, it's completely different. You see it is from fatty acids. It's much more in heart, and amino acids and glucose is much more in skeleton muscles. And this is interesting. There is some interaction, but if you look on common organisms, that means that different organs consume different fuels differently. And this is again which gives us a new tasks to understand how to do and how to measure that, and also even how to feed our, if I can say that, our organs, but on the other hand also how we can treat them. About precision medicine, if you look on maybe some, I'd say, more classical definitions, then you see the precision medicine is an evolving strategy for disease prevention and tailored treatment that incorporates individual biological, and there you see genetic, environmental and socio-economic factors. That's why I said it's much more than it looks like in one what we teach in Faculty of Medicine, and even what we provide in our hospitals. And again, if you look on others, then you see very well how it looks like. There is omic data, health system data, study participant generated data, motivation and behavior. And for example, this is it's maybe, but medicine is sometimes like a bit cynical, I'd say, but if we, for example, look on this motivation and behaviors, then we can say that this COVID-19 pandemic, it's not so much like health problem. It's much more behavior and motivation problem. For example, one small example, this is vaccination. And what I want to say, it is not only, this is like behavioral sciences should much more to be involved to fight with COVID pandemic. This is a question about precision medicine. And of course, there is also maybe, those are also pictures, and it is more for thinking and maybe to philosophy, how we should think in future, how we should go with our university, because if I can go with this to my chair in hospital, on board of hospital, they will say, listen, go to other doors, and it's not for us because we need to count euros how to buy. I don't know what, but doesn't matter. For example, this is again this lipid lowering therapy, so gene silencing technologies, and because the rector he's a master of different kind of viruses and gene transcriptions and other things, and we discussed so many times. This is the engineering that people say, what you do with us, you do your engineering, and we do something on our genes, but of course it is completely different, because this is only works on very small parts. But for example, this new model of this SK9 monoclonal antibodies really can decrease the level of our cholesterol. And now, if we look a bit on future, this is long-term stable reduction of low-density lipoproteins and non-human primates following in vivo genome editing of PCSK9, and there is a very interesting data how we can go further, and actually how we can improve our cardiovascular profile. And then, for example, again, what I said about this gene silencing methods, then this is a low-density lipoprotein cholesterol lowering strategy and population health, and you see that actually with every new agent we can reduce the risk of coronary heart disease. And this is so interesting. And for example, it was a bit like Plato for something new in last maybe I'd say 10 years. Now we have very revolutionary signs and signals from different kind of drug therapies. That's why we discussed, for example, we have this synthetic drugs, and I'd say years ago that it will be a future, and what we see here. About the genetic risk adherence to healthy lifestyle of coronary disease, this is quite interesting. We saw that the genetics influence more. Now we see that actually the lifestyle and adherence, maybe it's even more than some genetic impact. And I understand that it is a too long lecture, and that I will not go in details, and there is but I guess I have a couple minutes or something like that. Then what I want to show you that again, that the precision medicine in cardiovascular disease, again what I said, the genetics and the impact of phenotypes, and you see very well that combining both accurate genotype, that's why we should go again in both directions with what we are started. Information with detailed phenotype assessment provide a platform for precision medicine. The problem is that how we can do that in an accurate way. The phenotyping, the detailed phenotype, and actually the genotype. And if we not to do this in accurate way, if we not to do this on robust way, of course the decision will be wrong. And I see so many put this artificial intelligence, and I also like this terminology of artificial intelligence in medicine. But my friends, not only here in Latvia, who is really working on IT sphere, but also in states and everywhere, of course, the term of artificial intelligence is quite, I'd say, at least we can discuss about that, because first of all, what we need to get and to prove a robust data, and to understand how our genetics or genotype are impacting on our health. And the same thing is with phenotype, because what does mean the high resolution imaging. And if even we are getting a high resolution imaging, we should understand that. We should can to read this, and for this reason we need to learn and to do science of this. we have a bit of problem for that. And I can tell you, because I'm even not a radiologist, but I'm a rentgenologist. My first profession was rentgenologist. And that time in our country it was Rengen, named by this guy. Here you see this modern CT imaging, and of course it's modern or not, but for example in Germany, especially for strokes, they do, as you see in ambulance. In ambulances, the portable CT, and then we discussed, because it is very important. Sometimes when patients are coming to ambulance, then they know, is it a hemorrhagical or ischemic stroke, and from that it really depends. Quick and fast treatment. This is one other interesting thing, how we put together physics and engineers and surgeons. There's two of my very close friends, and this is Charlie Taylor and Chris Zarinsky. He's a very, very famous angiosurgeon in States, from Chicago University and then Stanford, and now they did this and create this heart flow. And Riga was the place where we really to prove this from first case, and this is CT fractional flow result. That means that from one static picture we can with specific program, with specific computers, we can make, and I will show you what. And why it is important, because again, I will show you how in medicine coming this mathematical modeling for virtual stenting, for example, but which is very important that we can work together with animators and designers and all those pictures, and actually this model, like animation model, did guys who did this movie Jurassic Park. Now I understood that it is an old movie, but when I started with those lectures, that time it was even quite known movie, and it's also coming from Steve Jobs' this lab. And this is the example, and then again, what is important, that it is like personalized medicine. We can from each patient know to modeling how and what we will be, how we should treat, and what we will be, for example, what will be the best solution, for example, for this narrowing of vessel. First of all, we understand, is it significant functionally or not, and then we can predict, for example, in that particular case, if we would put a stent, what will happen with function in vessel. And it is not like for many people, it's for one individual person. And of course it's not only about that, and this is why I'm talking about those necessity to put together different kind of sciences for better life. Now, again, if you look here at the CAS lab, as I showed before, this is like intravascular ultrasound, this is optical coherence tomography. Here you see, and we can analyze the plaque, and is it calcified, is it a fat there, is it a fibrofat, and this is a very new, this is near infrared technology. And with this we can even actually it will really be interesting to understand the evolution of atherosclerosis. And now we are, and this is all those pictures from our hospital, from University Hospital, is done by here also in Stradins Hospital, Latvia, and the University of Latvia, and this is very interesting. We should know to put this together with positron emission, and then we will see how it will work. If you look on future, there is and I guess many of you seen that this is of course the Google glasses, and we will work in very near future with holograms, and actually for each patient we can put patient's heart in our hand, and to go and to look and to understand what would be the best solution to do. And of course, this is again, I'm coming back to this artificial intelligence, but intelligence in precision cardiovascular medicine, and then you see what we can do and what we should do with big data. But if you look, what means is big data? This is a lifestyle, this is genetics, this is diet, this is gut microbiome, this is precision medicine platforms, this is wearable technology, omic data, and you see this even social media. And only if we can put this all robust data together, then we can go for this and to ask this artificial intelligence to do something with that. But actually, the end of the day, if we to put not the right data inside, then unfortunately the decision from this artificial intelligence will be wrong. And I'm a bit afraid how we can do that and how we can prove in this changing world what is the right, this robust data. But of course we should work on this, and this is how we see a world. Of course there will be the 3D printing, competition modeling, and here you see on this slide very different kind of possibilities. There is a very interesting again things how we do together with physicists and engineers and new devices, how we with one suture can save. This is a mitral annulus, and how we with one suture can save patient lives. And of course, all the time we do the evidence-based medicine. That if we even talk about precision medicine, it should be based on evidence-based medicine, only with new tools and with new systems. And that means that we still should work in animal labs. This is what I will go next week again, and there will be, this is I guess from Helsinki or from Paris, and doesn't matter, but this is the first how we do this experimental work, how we use this is a surgical ring in mitral valve, what we will go to use in percutaneous manner, and this is one of the startups, and it's of course not going so quick, but what I want to illustrate is that of course we can talk about very computational things, but we still need to do with hands something, and to do in good way, and also to understand anatomy, physiology, and pathology. This is one of the other things how we can use it. It's everything done by us or in Riga, and that's why I want to say and even to show to maybe faculty of medicine and directors that we also do something, not only how to say expressing in different kind of meetings But about future innovations, this is also very interesting way. Very good friends of mine there is what do this stereotaxis, and there's two very big, huge magnets, and you see it's of course it's like there I'm like actor, because it's not my grandson. He's playing very quick and everything with, and I guess you too, but for me it is of course will be difficult, but of course then the future in bit in joysticks and in big screens, and as you see this we can move catheter very precisely in this magnetic field, and this is also, it's not the future, it is the present time, and one of my younger colleagues, she's in Rotterdam and doing procedures second year, and learning, that's going for learning curve, and hopefully next year will be back, but again we need to introduce this. And what I says, this is so important how we should put together and genetics, genotype, and this high resolution imaging, and for example here in precision medicine and artificial intelligence in cardio-oncology, and because if you use anthracycline or other medicine, or if you use, and we should use, of course, we should use, but it also goes with some complications, and that's what we need to know, and specifically why we are talking together, oncologists and cardiologists. This is also some pictures on how it could be in future for prediction of coronary artery disease. There you see different ways, and we should analyze this in one with machines. I like very much, of course, I'm not doing selfies. I'm trying to show what we sometimes documented, what we do, but this is very interesting how cardiologists and people from different kind of specialties know we are working, but this is of course Professor Krams with his colleague and project director. We are working like university in Gene Date Lake project in Latvia. Also there we have our government agreement with Microsoft and Roche company for liquid biopsy, and here's the professor also Isaias who is involved in this project, and for very revolutionary idea about liquid biopsy for lung cancer diagnostics, and I really hope so that it helps us to also to be in the stream of development of precision medicine. And as usually I am finishing not like this cartons. I mean, the oldest who says that we should destroy a car attack, but I always finishing with a very, I guess, picture what I like very much from Leonardo, who was, I guess, one of the fathers of precision science, because he was like guy orchestra who he did so many things. He was an artist and engineer and philosopher and you know, and you see that even every detail, everyone knows what is about Gioconda's eye, but then you see that this eye, which is a detail in the whole picture, it's also I mean, the sum of other details. But of course we should understand, we should look on details, but we should not forget this whole picture, and that's what I want to say, and thank you very much.
Thank you very much, Professor Erglis, for brilliant presentation. Are there any questions from the audience? I would like to ask one short question, also have one comment. What do you think about the stem cell technology in the precision medicine and the role of the stem cells?
Yeah, you know, we are also, it was just, I'd say we have quite nice experience with autologous stem cells in different kind of organs, and I mean we started with heart in 2008 first. We started a bit before, but in clinical practice we started in 2008, the first one, and what we seen that it really helps, and it is if you do this in the right way, then it's really safe. But again, this is autologous only, and the same thing is one of our guys who is in orthopedics school. He did his PhD, and he proved that even for cartilage, this cells and autologous cells is better like hyaluronic acid, which is a reference. And for this reason, and also we did a very interesting job which published in Cardiology in Young in UK. I mean, for newborns with cardiomyopathy. Sometimes we don't know exactly the mechanisms, it could be also so many layers of things and then maybe triggering things. But clinically we see, and the whole world working on this, it is not so easy. There is ethical things, there's other things, but I really believe that it will be in future, and I really believe that it is a huge future. And actually then the hospitals or scientific organizations will actually be like factories of health.
Thank you. And I also would like to stress out, so we have our aim of our conference, so at university perform a lot of research to implement in clinical practice, and we have very good example which Professor Eglis have mentioned, that University of Latvia started project which is supervised by Professor Eglis about lung cancer and liquid biopsy, and since this year this technology, liquid biopsy for patients with lung cancer, is also reimbursed from the state. So the university was the first to show this clinical need in real practice, and now it's also reimbursed by state. I think there is very important role of a university also in the healthcare of the system. It's a very nice example how we can move and really to help the patients. Any other questions? Okay, if no, the next our lecture will be online, which is by Professor Marcis Slayer. We will load it.
Labrīt. Mans vārds ir Marcis Slayer. Jūs redzat, dzirdat mani, tad varam secināt divas lietas. Pirmkārt, jā, man kāds ir līdz informācijas aizsardzības tāds ar komandējumiem, es neesmu uz vietas, un otrkārt, organizators šo manu ierakstīto uzrunu ir saņēmuši. Es tālāk turpināšu audio. Good morning, my name is Marcis Slayer, and this is my pleasure to speak to this audience today and present some of the data, and I will be showing my screen in a second to speak on new technologies of cancer detection and the use of large data for cancer detection. So the agenda of my presentation is the following. I will briefly touch the priorities of the European Commission in beating cancer. I will speak on the study that we have launched in Latvia together with the International Agency for Research on Cancer, GSTAR study, as well as on the data collaborative with gastric cancer as an example. And I will touch also the use of new technologies. In particular, I will be speaking on the detection of volatile organic compounds in breath for cancer once more. And to start, cancer has been put in the focus of the European Commission, and this has been already elucidated a few years ago when the European Commission has decided to define altogether 5 mission areas. And those are definitely, all of them are related to health. They include adaptation to climate change, healthy waters, smart cities and climate neutral cities, soil and also related to this food safety, and finally, but not least, cancer is the only topic that is defined in the mission areas in the healthcare segment, or even more broader by medicine in total. And what is being defined by the cancer mission, the mission area has really been putting very important goals, in particular to save 3 million lives by 2030. And to achieve this, the main emphasis has been put on prevention. Those are the three general pillars. Then also optimization of diagnostics and treatment, support of quality of life, but definitely around all these three general directions, it is equitable access to everybody and understand or research that is also goes parallel to all of those pillars. Furthermore, there are further also cross-cutting areas, cross-cutting actions. And the European Cancer Mission Board has defined 13 recommendations, and I will briefly go through those. Those mission areas are divided into once more similar to what I described the pillars before: the understand in light blue, prevention in green, then diagnostic and treatment, quality of life, equitable access, and finally cross-cutting actions. So first of all, the first initiative, the UNCAN initiative under the Understand recommendation, this is the only initiative that has been launched already this year. The other one is aiming at identification of polygenetic and genetic risk scores, very closely linked also to individualized approaches. The next two, number 3 and 4, go under the prevention, and number 3 is more targeted to general political decision-making authorities, includes the taxation and other issues that we expect to be related to effective cancer prevention. Furthermore, number 4 is optimization of the existing screening programs and developing new approaches. The next two, number 5 and 6, are aiming in particular, number 5 is aiming personalized medicine approach in oncology, and number 6 is EU-wide research program on early detection and minimally invasive technologies, meaning aiming at new technology development. Next two recommendations related to the quality of life is to develop the EU-wide research program to improve quality of life in cancer patients, and not only cancer patients, but also survivors, family members, and caregivers, as well as those that are at increased risk for cancer. And very interesting aspect and very important aspect is number 8, that is creation of a pan-European patient-oriented digital center where patients and survivors can deposit and share their personalized data, meaning that patients are in the center and should determine which data should be shared and which not. The next two in blue include the equitable access. Number 9 is defining cancer health equity in EU across the continuum of the diseases, meaning at very different aspects of consideration. And number 10, once more, a very important aspect to my consideration is to create a network of comprehensive cancer infrastructures across the EU, meaning that comprehensive cancer centers should be present in every EU countries, and those should be networked in between themselves. And then finally, the cross-cutting recommendations include childhood cancers, include innovation and implementation of new technologies, and that's what's very interesting there is the recommendation to implement oncology-focused living labs. And finally, number 13 is transformation of culture, communication, and capacity building. So, what has happened thereafter? Those recommendations were already out a year ago, but during this year, the European Commission has come up with another important document, European Cancer Plan. And this plan is developed by another directorate of European Commission, by DG Santé. And based on this, a new program has been already launched. It is EU for Health program to support those initiatives. And what is really very attractive that there is very good parallels between the two documents that I have been mentioning. European Cancer Plan has been considering a lot of the cancer mission recommendations. Furthermore, there's another area of importance, that is a digital health, and here what is in the focus of European Commission. And also this is concentrating a lot on the aspects that have been touched upon before. So how we can utilize and how we see the place of Latvian research and clinics in those European programs. And I will speak first on this G-STAR study, what I have been mentioning. This is a study to prevent predominantly gastric cancer, also colorectal cancer. But first, for the introduction. Many might have heard that the incidence of gastric cancer is declining, and there has been a viewpoint that it will be a self-disappearing problem as well. Is this really the case? Probably not, because according to those estimates by Global Candidate Base for the new number of new cases globally, currently the number of new cases exceeds already 1 million. Previously it was slightly below, but it projected 20 years ahead for 2040. The number of new cases is not going to decrease, but it's going to increase up to 1.77 million. Similar situation I'm not showing here is attributable also for Europe. So then if we are speaking on screening, what approaches for screening of gastric cancer, or what approaches for prevention to decrease the mortality from gastric cancer could be identified. And those, sometimes if speaking on cancer screening, we need to understand indeed what we are speaking about. So we might be screening for the cancer itself, and in this case it will be mainly endoscopy, but also this could be barium swallow in East Asia. We might be screening for precancerous lesions, and the most studied test there is carcinogen detection, but it could be also screening for Helicobacter, the causative agent of gastric cancer, and in this case it would be search for infection even in subjects without the precancerous lesions to eradicate the infection for the prevention purpose. And actually this is what has been recommended by the recent international guidelines, namely Type A Global Consensus, the publication of which you can see here. And this is going to be endorsed further by the European guidelines, Maastricht Florence guidelines. And when you will be listening to this presentation, probably all of those statements, what have been cited here, when I'm recording the presentation, they are just in the draft version, but by September 30, they should be voted and probably will be accepted for on the professional society of Europe. And just to point out what they are recommending, population-based Helicobacter search and treat program that should be integrated into the healthcare priorities in regions with intermediate to high gastric cancer risk, and definitely Latvia is a region attributable to this. And all the other statements are maybe less important for this, but I think that is a principal one. So while we are not going immediately ahead and introducing this approach, we do have also several other guidelines and or recommendations from the expert group. The first one was accepted by the end of 2013. The other by the European Screening Expert Group a couple of years later, by the CONCON working group, it's here. And both of them are saying that yes, we need to have gastric cancer prevention in Europe. However, it has to be still additional data available before it could be recommended population-based. And actually they are calling for the necessity of such studies, even mentioning the G-STAR study I'm speaking currently on. So this is a G-STAR study. The protocol has been published a couple of years ago together with the International Agency for Research on Cancer. This is briefly the design. 40 to 64-year-old individuals are being enrolled, and actually they are randomized to two groups. And in the intervention group, Helicobacter is being tested, but also carcinogens are being evaluated, while in all the study cohort, fecal blood tests are offered for colorectal cancer screening. In the case if Helicobacter is found to be positive, eradication is offered to those individuals. If pepsinogen levels are found to be altered, in this case, upper endoscopy is being recommended to those study subjects. And the results actually are not expected to come very early. We expect to have them 15 years following the enrollment in the study, but the enrollment hasn't finished so far. So what is the situation right now? And we are proud to tell that as for now, more than 10,000 studied individuals have been recruited since 2013 in Latvia, and the recruitment is ongoing currently in the regional city of Viena. This is briefly the statistics. More than half of the individuals are infected to Helicobacter. More than 2,000 have completed the eradication treatment, and considerable number of endoscopies have been performed, and altogether the number of years of follow-up for the time being is exceeding 37,500. So this is a recent publication of the study. Very important aspect on the acceptance of this strategy, showing that definitely not everybody is accepting, but a significant proportion of individuals is. So would this be enough to make any conclusions and recommendations for Europe? I assume that this will be a study providing important information for Europe. However, probably without intense collaboration in Europe, it will not be possible to achieve the set goals. So there, the data collaborative comes in. And we have initiated a data collaborative in close collaboration to Microsoft company that has been currently submitted to an EU data platform called IX. And this platform is intended to bring together either academia or industry as well. In this case, the initiator was Microsoft. This is a total number of use cases that currently have been defined, more than 70 altogether on the IX database, and there are more than 10 sectors, health being one of them, although so far there hasn't been any project, any use case being suggested from Latvia or even from the Baltic states. Those are some of the use cases within the health sector. Most of them are originating from Germany or from France. And what we believe very important is really that also gastric cancer data collaborative could come in and become one of the use cases within the sector. To facilitate this, we have been building up a model and the way how also not only academia but industry might be interested into this. This is a pathway from normal gastric mucosa to gastric cancer, and there are several ways, as I described before, to interfere with this to decrease the number of deaths that is being caused from gastric cancer. And actually this consortium that has been built under the acronym of CARICOL has been recently submitted to the European Commission by a number of partners that I will identify just very briefly. But the general idea of this data collaborative is to identify a number of sources that could bring in the data, to involve as much as possible stakeholders, of course, including either politicians or citizens or patients and academia, and really to aim for better outcome of either screening or prevention, but also treatment. And this is a project that we have been submitting, as I mentioned, this CARICOL project, in close collaboration to the leading universities in Europe, but also industry. Porto University, Erasmus University have been among the partnership, as well as University of Slovenia. And just to mention that Slovenia, we expect will be the first country to implement search and treat strategy on population-based settings, and that is what we have been discussing during the recent years with the colleagues from Slovenia. So finally, to touch one of the approaches that could really provide significant benefit for screening gastric cancer, but not only gastric cancer, other potential cancers, and maybe even not limited to cancers. And the concept is based on the fact that a dog is able to smell disease. A dog has been proven to be able to smell cancer. This has been proven in a number of cancers, and this publication we got, the leading journal in gastroenterology in Europe, has demonstrated that a dog was able to identify precisely colorectal cancer with quite high accuracy. And this has been, as I mentioned, proven also in other cancers as well. So, what are the approaches and how a human is trying to copy what the dog is able to do? There are two principally different approaches. Whether to measure particle chemistries in the exhaled air, and the typical example for this is gas chromatography coupled to mass spectroscopy, and those peaks are just allowed to identification of particle chemistries, what could be found in the exhaled air. The other aspect, the other possibility, the other approach to breath testing is similar like teaching a dog. It is based on the sensor technologies Usually sensors are cross-reactive sensors that do not allow to distinguish particular chemistries. They allow distinguishing a particular pattern, breath pattern. In this case, that is characteristic for one disease or the other. And how it's done, it's likewise the dog is being educated and trained to distinguish and to separate disease from the control condition. The same is done actually with mathematical methods based on the readings from the sensors. Usually those are chemoresistive sensors, and then the classification is being made based on this. Furthermore, when this model is being applied to a new cohort, we can evaluate the accuracy of the method in the new cohort. And in the case if the method works well, in this case it would be a perfect method for screening purpose. First of all, being non-invasive, low cost, results could be potentially available on the site. Surely that is not the case in the study settings, and the technology could be portable and definitely easy to operate as well. Whether a handheld one or a tabletop one, it doesn't make a big difference. And let me allow to take you through the studies we have been involved that have allowed identification of gastric cancer with the sensor approach. This is the first study, and the first two studies actually that I'm going to show are based on a laboratory-based sensor readings, meaning that a breath sample has to be collected and transported to the laboratory. This study has been originated in China, so the patients have been enrolled in China. Actually, in parallel, either the GCMS or the sensor analysis were done in laboratory conditions in Technion University in Israel. And sensitivity and specificity for the method, the sensor method for identification of gastric cancer was surprisingly high, 89 and 90% respectively. The other study that has been conducted in a similar manner was based on the patients that we have been enrolling in Latvia, and once more the samples were sent to Technion. And once more, high sensitivity and specificity were achieved for gastric cancer. In addition to this, we are addressing also the performance of the approach for detecting precancerous lesions. It was somehow lower as anticipated, but still quite acceptable. Within a project that has been funded from Euro-Nanomed call, a tabletop instrument has been built up, and the big advantage of this instrument is that different sensors can be exchanged and placed into one instrument. In particular, that is important for the study purpose because you can identify which sensors are working better and really stick to those, and this prototype is still being used in other studies as well. So the follow-up study once more on gastric cancer SNP was first of all trying to miniaturize the technology, and those are the two instruments that have been developed within this international study funded from the Horizon resources, but also to allow the possibility to connect it to internet or to mobile telecom. And in this publication, recently published in Cancer, the Journal of American Association, good sensitivity and specificity have been demonstrated once more for gastric cancer, although it has to be mentioned that the performance was lower in the case of other instruments than those with whom the model has been developed, we are involved to the evaluation process. And finally, this concept has been continued and is being continued still with the current project with the acronym VOGAS. That is involving once more multiple sensors, gold nanoparticle sensors from Technion University, nanoporous metal oxide sensors from Uppsala University, also commercial metal oxide sensors, and infrared spectroscopy waveguide sensors, and that is done for the first time from the LU University in Germany. The instruments have been produced, 6 prototypes altogether. 2 of them are currently in Latvia and operating in Latvia, so we are really excited to see the results, and this study is being performed also in collaboration to colleagues in Latin America, where also the burden of the disease is high. So to summarize this up, the volatile marker concept has demonstrated high sensitivity for gastric cancer detection and high specificity, somewhat lower for high-risk precancerous lesions, and either in respect to sensitivity and specificity. However, if asked whether the technology can be applied to practice immediately, my response would be that unfortunately not yet, because more studies are needed to demonstrate the robustness of the technology, the reproducibility, the instrument-to-instrument variability, but I hope this is coming soon. So with this message on volatile marker detection, I'm happy to end up my presentation, and in the case if I will have the access to internet, I would be absolutely happy to take the questions. Thank you.
Thank you very much, Professor Lea, for the presentation. Any questions from the audience? So the next presentation will be about by Professor Gershkevich. It will be online. Dear Professor, do you hear us?
Good morning, everybody. My name is Edward Geshkevich. I'm head of medical physics in North Estonia Medical Center in Tallinn. And I'm going to present you a little bit of developments in radiation oncology. So let me just load up my presentation. All right, I hope you see it and hear me clear and loud. So first of all, a little disclosure. So we have a working collaboration with a Finnish company, Envision, who is developing AI-based solutions for automated contouring and radiotherapy. So the outline of my talk is what is AI? I think the first speaker already mentioned several times the use of AI in medicine. So I'll just briefly touch upon that. The second question is why to use it in radiation oncology? And the third one, where to use it in radiation oncology. So just a little bit of terminology, you know, that artificial intelligence is just a concept which have been already for a while around. I mean, you remember the chess games of the Garry Kasparov and the computer, and in 1997 the computer actually won. So that's, but actually the concept was developed in the 60s of the last century. And it was slowly kind of maturing. The second is machine learning. So this is a subset of artificial intelligence branch, which is developing algorithms which is focusing on the machine itself to learn from the data we supply. And then basically they can learn it without the human interaction. And the latest developments which are boosting now in the past 10 years, I would say, is deep learning. And this is another branch of the or subset of the machine learning and artificial intelligence concept that it's actually trying to mimic the human brain and neurons. So there is several layers, and it's trying to extract the features of the certain input which we are giving to the system and trying to predict or provide the output. So in a shell nut, it looks like this. So, and for example, the auto-contouring tools which we use in radiation oncology is based on the deep learning algorithms. And the reason why it's only came around 10 years or less than 10 years ago is mostly related to computer developments and particularly to GPU or graphical processing unit, which you know, video game users are definitely know very well. So that's a powerful tool to calculate quickly large sets of data. So, and that's the artificial neural network. So you see, you need to have an input, and then this input is segregated on a number of nodes, and then it creates the output. So you can supply something which the system has never seen before, and it tries on a previous experience provide some reasonable output. So why to use it in radiation oncology? What is radiation oncology? You know that radiation oncology is using ionizing radiation to target cancer cells. And it's quite a complex process because it involves many professionals, it involves many technological equipment, linear accelerators, treatment planning systems, operating systems, information systems, and there is a lot of data generated, either as input and as output. So this all together provided quite a big environment where the machine learning and artificial intelligence can take part. So this is, let's look now at external radiotherapy treatment planning process. So it starts with a CT data or MRI data or PET data acquired from the patient who have been diagnosed with a cancer. And then what you need to do is you need to define the structures. You need to tell the system, I want to treat this part of this tumor, and this is a critical organ I want to avoid so that radiation is not passed here. So that's the part of the anatomy. And it usually takes quite a number of days of different specialties, including radiation technologies, radiation oncologists, and medical physicists to prepare the case. And then it goes to the planning, and the planning stage is where the medical physicist or dosimetrist tries to put the beams around the patient in such a way that it targets only the tumor and tries to spare as much as possible normal tissue. And the whole goal of that is optimization. As you see, there is a second loop. So once the physicist is producing a treatment plan, the physician will evaluate, the doctor say, well, no, I don't like, this is too much dose to that spinal cord, for example, and we don't want to treat that, so please do re-optimize. And it goes to several group of manual iteration. So, and the whole process would take up to 2 weeks before actually patient get into the treatment machine. So, and this is exactly the area where there is a lot of interaction between the different machines. So there is different equipment talking to each other, CT scanner, to treatment planning system, to contouring, to record to verify system, and so on. And also different specialties. I already mentioned radiation oncologist, radiation technologies, dosimetrist, physicists, so on. So you see, there is a lot of issues could be happening. So organ contouring, if you take, I mean, that's the thing what radiation oncologists do, to tell the system what I want to treat, what I don't want to treat, and this is currently done manually. So basically on each CT slice or each MR slice, the radiation oncologist or radiation technologist define the structures manually, just drawing them, sitting and drawing. This could take hours of the doctor time or RTT time, and especially if you would like to do a more advanced techniques of radiotherapy delivery, such as intensity modulated radiation therapy or volumetrically modulated radiotherapy. This would require a large number of organs to be drawn, because if you want to protect, and this technology will allow you to protect some structures, you need to define them first. And the manual contouring is time-consuming and also is user-dependent. So if you ask 2 radiation oncologists or 2 radiation technologists to draw the same thing, they do it slightly different way. So it's a human-dependent or it's operator-dependent. And also there is a new concept now in radiotherapy which is called online adaptive radiotherapy, where the radiotherapy is adapting to the changes which the patient have from a day to day, because as you probably know, radiotherapy is taking 5 to 7 weeks of treatment, and obviously the body and the organs and the tumor is changing during that time, and the concept is that you take the image every day, you adapt the treatment on a daily basis, and so on. But this again requires to redraw all those contours what you've done initially. So that's just multiplying the work of radiation oncologists. And also, if you look from the accuracy or safety perspective, and this is just the different aspects of the radiotherapy, the symmetry delivery, set up the patient on the machine, the movement of the organs, biology of the tumor, and target delineation, you can see that the biggest uncertainty is the target delineation, and this adds to the overall certainties of the treatment. So this is just an example of that. 6 different radiation oncologists being asked to draw the areas, what they want to irradiate. So that's the lymph nodes of the head and neck region. So they were given the GTV, and GTV is the gross tumor volume, which was identified on a PET scan and on palpation. And as you see, all 6 draw slightly different regions of volumes. And based on that, then the radiotherapy plan will be created. And as you can imagine, that would be radically different between these 6 cases. So that's a variability which we currently see with the human operators. So, and we have conducted some studies on the contouring, and in this case there was a prostate cancer case, so it's a pelvic region. So, and we discovered that the artificial intelligence-based contouring could spare up to 70% of contouring time. It still requires a little bit of modification because some of the areas may not be well represented, and in that case the radiation oncologist or radiation technologist will go and modify these, but that is only 30% of time which was originally spent. And if it's a 3 or 4 hours, you can imagine that you can cut it down to 1 hour. And the other thing is similarity to a true value. And this is very often compared with a dice coefficient. A dice coefficient of 1 means that the two contours are perfectly overlapping. So, and as you see, and it's considered the difference between different human observers or outliers is about 0.8. So if you are above or around 0.8, then you do as good as people already. And you can see that in majority of different structures that was the case. So just a quick example how it looks like practically. So you see you load up the CT images, and in about 2 minutes time, so in 2 minutes it takes the time to generate the contours. You can see different contours appearing on the screen. So let's see if I can, yeah. So and you can see it's, you know, all bowel loops, the spinal cord, and the prostate, bladder, rectum is all automatically drawn within these 2 minutes. And what then the radiation oncologist is required to do is just go through and see if the contouring was done properly. But that would need to be done in any case, because then the radiation oncologist is the person in charge at the moment who who ensures the safety and adequacy of the treatment. Just another case, maybe this is the head and neck. Again, about 3 minutes. Obviously, this depends on the number of slices you upload, and it depends on the number of structures. As you see on your left, the number of structures here is much higher, it obviously takes a little bit more time. But as you see, parotid glands and lips and so on, it's very well drawn. And otherwise, this all needs to be drawn manually on each individual single file. So again, this is a huge time saving for radiation oncologists. So of course, if there is a problem, any problem, as you see, and this is just one example. There should be more problems, of course. As we implementing new technology, it's always something which is not expected. So here is the same patient. So it's in one case it was manually outlined, another automatically outlined. So this is the prostate. If I take a closer look, what you see here is a fiducial marker. And fiducial marker, this is a gold markers which are implanted into the prostate in order to track the position of the prostate during the treatment. And in this particular case, urologist who placed the fiducial was missing the capsule, and it was just outside in a muscle, placed in a muscle. But what the artificial intelligence saw, because it was trained on the data, where the fiducial should be always inside the organ. So you see they included the fiducial inside the prostate, so basically making that loop. And so that's exactly, giving us whatever you give in, you get out. So it's rubbish in, rubbish out. And of course, it's very critical what kind of data you supply to machine in order to have as a training data. So we now go back to our original scale, which takes up to 2 weeks. So if you put an artificial intelligence agent here, which can do anatomy, contouring, and outcome, can do a treatment plan, then you can dramatically cut this down. And the treatment plan again, so you can see, for example, so this is again an example for the prostate cancer case. So you see different colors means the different doses, dose distribution it's called. And you see the prostate in here, in red, and in blue you see a rectum. And what you can see between these two is that on the right-hand side, which was automatically planned, you see a bigger sparing or less dose inside the rectum. And it's known that the rectum is a critical organ for the prostate, the radiation, because it's right close to the prostate. So again, you can see that artificial intelligence can actually do a plan which is better than what human currently do. The other aspects of the human, this is just a plan challenge. So the same case was sent to 125 different planners in different countries. And they were asked to do a best plan what they consider. So they did a plan and sent them back with diagram images. And then they scored in terms of the plan quality score. Plan quality score means that, if you are sparing many organs at risk and you're targeting your target very precisely, so then you get a larger score and vice versa. And you can see how huge this variation is. So depending on in which clinic you go, you are likely to get very different treatment plans, obviously, and it will result in a different, therapeutic outcome. So again, there was a study led by the Erasmus Hospital Rotterdam on the fully automated multi-criteria planning for the prostate cancer. And what they discovered, the machine was generating the plans, the human were generating the plans, and then there was a blind clinician side-by-side scoring of the plans. So they actually were presented two plans. They didn't know which one is which, and they were asked which plan you would propose to your patient. And the majority is actually in favor of auto-planning. So some were also slightly better auto-planning, and there is a equal and then the manual plan. So it's actually, if you compare the best plans and the worst plans, so it's a 738 versus 9, so it's 75% were roughly for the auto-planning, and in 85% is the human were actually better. So in conclusion, AI can, I already showed you two examples where AI is working now. It's auto-contouring and auto-planning, so which will streamline the process, harmonize the practice and actually efficiency. But you can also use it in decision-making, whether this patient needs radiotherapy, whether it benefit from radiotherapy. Auto-contouring, I already told you. Auto-planning, I told you. Peer review of contours and plans. Even if you don't use the AI-based auto-contouring tool and you do it manually, you can still use the auto-contouring tool as a big brother tool. So basically to review your contour in an automatic way. So you draw something and somebody just review it automatically and present it with a difference. And the same goes for the plans to ensure that the good quality standard is achieved. You can do a physics quality checks. You can do it. The plan seems to be complex, whether it's going to fail on a QA. So this can be predicted by the AI. And the treatment outcome predictions, even before you start treatment, the AI can predict how many complications from this particular plan it could be. And another new developments nowadays is the treatment modality selections. You know that, for example, usually the radiotherapy is done with the photons or X-rays. But there is more and more growing number of proton centers, which are more, which have a better dose conformity and dose distribution properties. But obviously, it's not available in all countries, so you need to select the patient who would really benefit. And again, one way how you can do is that you can do two treatment plans, one for photons, one for protons. But that takes quite a lot of time. And what is now proposed is that the AI-based dose prediction, and based on those predictions, the patient can be randomized for the proton therapy if there is a benefit of that. Or if there is no benefit on the prediction, you can go with a photon use, so there is no additional benefit of protons. And that will dramatically cut down the time, which is the human resource, which would require now in order to do this pre-selection process at the moment. So and so on. So that's basically the list goes on because in any there is a lot of repetitive steps and a lot of steps by human, which actually could be automated and taken over by artificial intelligence. But of course, the important thing is that this is currently set as a black box. So and you need to remember whatever you put in, and if there is any problem or it's insufficient data, to cover your clinical practice, and of course that thus insufficiency will also will be present in your outcome. So at the moment still humans need to use common sense and guide this model development and implementation. So thank you very much.
Thank you very much for your brilliant presentation. Any question from the floor?
Thank you, Edward, for this really brilliant and comprehensive presentation on the data which you have gathered during your really already long-lasting practical work at Estonian leading radiotherapy facility. And the question is, of course, related to the scope and limits of the use of artificial intelligence in this and probably many other procedures. And the first question is, how much international cooperation should be involved if we want to develop such a comprehensive network of data sets, how those data can be evaluated and used then to create the algorithms for the artificial intelligence procedures. And once are there some, let's say, societies or networks created in the medical community which can cooperate in providing, as we heard already, the need for robust and reliable data for the artificial intelligence to be taught on. In your particular case, probably in other fields of medical research. This was one question about the database, let's say, scope for the training of this artificial intelligence. And the other question is, isn't there such a built-in fault or up in the algorithms, how we treat or how we educate the artificial intelligence, since anyway these are based on human made evaluations, human made contouring, so on, so on, so on. And as you showed already, there's such a normal distribution of best and worst and average results provided by humans, and the artificial intelligence, of course, will try to make some generalization of this existing data experience, of existing data sets, and in the end effect, apparently, to my understanding, they will come somewhere to the midpoint of this distribution, but it will be nevertheless not the best point. This will be just the midpoint of the distribution. Is it possible to train the intelligence how to approach, let's say, the best, but nevertheless underrepresented part of the human or this incoming data sets, in the same time having in mind that this in end effect may be a bit dangerous approach, because the genius and the idea, they are just very close on very, those distributions may not be just apart, but they will be on the circle very close each to other. And last but probably not the least, what I just recalled right now when I was speaking, you mentioned Kasparov, who lost to Big Blue already some time ago. It was apparently the second contest they met each other, and the first was won by Kasparov, and if I'm not mistaken, I still recall that the reasons of the success at the second contest when the machine won was the fact that some fuzziness was introduced in the programs which were creating the moves which machine made. So it was not very strict, it was somehow at least mimicking some human, let's say, unpredictability in actions. Is this a moment which could be or should be considered when we are developing the algorithms for artificial intelligence in that sense? Thank you very much.
Dear Professor, the floor is yours.
So can I answer? Yeah.
Yes, please.
Yeah, so the first question regarding the data. Indeed, this is a very crucial one, and there is several approaches. Either you do a collective data from several representative institutions, or you do it based on your institution. Yeah, thank you. So regarding the first question regarding the quality of the data, there is several approaches. Either you take the several well-known universities or well-known representative data and merge them together, or you do it individually based on your own institution. Obviously, the best choice, or the choice we currently use in radiation oncology, is to follow a certain guidelines. And there is several artificial intelligence vendors on the market, and they have all different approaches. Some was just using the big data, collecting from all institutions, whoever can provide the data they collect. So they not looked at particular guidelines, how, let's say, the contouring was used, but they just collected, they took the data, But it's actually what is now showing that it's better to follow a certain guidelines, because then they produce contouring according to that guidelines, and I think that's the best approach to take. Because and this is a criticism. I don't know if you heard, there is the same company IBM when they sold their computer business to Lenovo. They dived into the oncology business, and they started IBM Watson, and it didn't fly very well. I mean, the program is still open, and it didn't fly very well. And the reason for that was that their models and everything and the data for that models was based on Memorial Sloan Kettering Center, which is not, the worst center in the world, but definitely that's a single one. And that was a big criticism, that you took only one data from one institution, it's not representative, and it's the way how you treat oncological patients, whether it's surgery or chemotherapy or radiation therapy, is not representing the other parts of the world, etc. So yeah, I think that's two approaches, and for example, we used an approach based on a guideline, so there is a certain expert guidelines which have been agreed in society, for example, radiation oncology in European Society for Radiation Oncology, and then we follow that, and if the model is built on that, then it fits very well. But at the same time, I know that some people have a little bit of variation of that, and what they propose, and this is also possible with artificial intelligence, that you provide your own data, and for example, for the prostate cancer patient, this is something like 70, 80 patients, what you need, it's a minimum set for the training data, and you can build your own model, and it will then take into account your specific, specifics, if you like. Yeah, so that's everything depends what we supply to the model. If we supply wrong data or not representative data, the outcome will be exactly the same. But that's the same is the beauty that you can also fine-tune the models to a specific needs. And maybe, and this I see the best future, is that we can harmonize around the world that the patient will be treated exactly the same way to the best knowledge of evidence-based medicine. It's not like if you go to one clinic and they say, well, that's how we do, and this is, because then, first of all, we will not get a consistent output data, evidence data for the, if the drug or therapy works for that patient group, because we are diluting by introducing variability. So that's my take on that. Regarding the fuzziness, and yes, this is a black box, so you can obviously mix up some of the things and maybe, because at the same time, the artificial intelligence is basically following the human, yeah? What I'm gonna tell the system is gonna be formed. At some point in time, and that's, people telling about that maybe a machine will, start to develop their own opinions and maybe would be outperforming humans and also doing, things which human would never consider, etc. I think we are still not at that stage, but that stage will come. And we need to be ready to control the machines in order for them to not take over us. I mean, they definitely can help us, and I see it's like a help us, but not like a full replacement, I think, because I think humans have a common sense and things like this, which probably are, machines like artificial intelligence will not have in the near future. So they just be doing a specific tasks, yeah, but that's a big Pandora box, yeah.
Thank you very much.
May I ask a very short question?
Yes, please.
Thank you very much for a fantastic presentation. It's really, really nice, and I guess it is so important to discuss about that. But you mentioned in last your phrases that machine will take decision, and then it's always a question what we know. Like I'm also doing something like in invasive cardiology and surgery and so on, and then it's a question who will be responsible. And how you can think how we can involve machines. And actually I also can say that with mathematical modeling and with IT, these technologies I'm working for the last 20 years at least, and how we can involve machines in research, because this is a bit, questions. I guess maybe then we should start first to understand actually this a bit bigger, I mean the system, because otherwise how we can prove that machine will take a right decision. Thank you.
Dear Professor, could you answer the question? I guess we have some. Yes, okay. Professor, please.
Yes, so basically, that's a good point, but we need to have a robust quality assurance. At the moment, the quality assurance is a human who is, evaluating what the system does, because at the moment the radiation oncologist is responsible, right? So whatever machine does, whether it's creating a plan, whether it's contouring certain organs, the radiation oncologist is responsible to make sure that those are correct, because they will be used for patient treatment. But in the future, I think that one of the possibility would be to use another artificial intelligence tool to verify the first. based on a completely different data, because this kind of approach, it's from radiation protection, it's called defense index. If one layer is failing, and like in reactor, then the other step will take over and so on. And by having completely independent systems, having a completely independent training sets in those systems, and if they arrive to similar results, would already quite, definitely the errors could still slip through, but the likelihood of errors will be minimized. And I think that's also a very promising approach, that you have the two artificial intelligence, one is verifying the other. Of course, assuming that they are independent in terms of the model and in terms of the training data they build upon. Regarding the research, I think at the moment, again, machines are built on what we want from them, but you need to introduce some kind of uncertainty in order for the machines to think outside the box, like human, like a great genius or painters are doing. I'm not sure if the machines at the moment are capable of doing that. You need to think outside of the box, not what you are prescribed, because now machines are helpers. They are decision support systems. So they are based on algorithms and the data which we know and we supply to them. But will be the step when the machine itself will create something that any human will not do it. Music, for example, or art. It's probably possible, but then you need to introduce some degree of randomness or spontaneous to that. And I think that's becoming already dangerous, because then you cannot assume or you cannot predict what machine outcome will be.
Thank you.
Thank you very much for your brilliant presentation. We have very productive discussions on this topic. It's very interesting, thank you very much. So we have finished the first part. We have 20 minutes break, and we will continue after 20 minutes. Thank you. Dear colleagues, we will continue our conference, and I would like to welcome for the lecture, for talk, for modern surgery, for robotic surgery. It's my great pleasure to welcome Professor Dali to give his presentation.
So, and just before the presentation, I will say some greeting words for our next lecture. First, I met Dr. Adali most probably approximately 7 years ago, and at the time I was young junior doctor of urology, and Dr. Adali was already a well-established urolog working at one of the biggest European robotic centers in Gronau. Now he's chief of urological department in Siegen. Dr. Adali is one of the few wholly compatible urologic robotic surgeons who is able to perform the whole spectrum of robotic assisted urologic operations, inclusive radical cystectomy. That's why you should be honored to have a lecturer of such qualities over there. Please, Mustafa.
Thank you. First, I will thank the scientific committee for the invitation and to be here in Viena. And I want in the next slide to share with you my experience in minimally invasive surgery, especially robotic surgery. I start with this system in year 2008. I moved in the time from University Hospital in a small country hospital, because was there a person who had a vision, and there was one of the first hospitals in Germany, in Europe, where they brought this technique from US. And now after mostly 12 years, it's the largest center in Europe, according to Da Vinci systems. They have now more than 6 systems in the department. And last year or this year, I moved from this hospital to another center, and now we start also in Siegen with 2 robots, and the plan is also there in this city near from Frankfurt. In the next few years, we make the same story what we started before in Gronau in the north of Germany. When we talk about innovation, we have also some old things that change with the time. Also, the value in the healthcare has changed in the last 20 years. In the past, when you talk about value, you talk only about quality and about service. That's what. But now, since 10 years, if you talk about value, you have to think also about outcome. Patient experience now is more relevant. If you can perform the best surgery, but if you don't have if you have an unhappy patient, it means that you make something wrong. Also, you have to think about cost, because you have direct cost is according to surgery, but you plan also indirect costs. That means length of hospital stays, how many days is the patient outside from his work. Also, if they need rehabilitation, the time from rehabilitation, if they need painkiller after large surgeries, all the things have to be in the mind when you plan now surgery. That's why, what I said before, you have to think how you create and to assess sustainable value in your daily practice. In the history, when you are the surgeon, if you are the head of department, you are really the boss and you can do everything. Robot surgery is completely different. Robot surgery is a teamwork. You have to think completely different. You have to put your team with you. You have to deal with different kind of complications. You have to be really a manager, not only a doctor. You have to plan your assessment, to get data, to get all the time training. You can say, okay, I get my training, I am now robot surgeon, I can stop, I can do everything. Now we have kept everything, you have given touch, and you give movement. That you can reach at the end better patient experience through all these processes, and at the end, the care team experience have to be also on the top of your planning. That is a short preview how when I moved when I planned in Grunau 2014 to go through robot-assisted radical cystectomy is one of the most complicated challenges surgeries in the urology, not only urology, also in the general surgery. I made a plan, and it was based on two tools. The first one was an segmented management phase, and the second one was the integrated standardized management. And I put all my energy in the first time to see which evidence we have now today. And I put all my team, that's mean not only the surgeons, the nurses on the ward, the nurses on the periphery station, the government, people who will invest in this program. And only if you plan really correctly, if you want to start with robotic surgery, you can get really success. And you see that took more than 1.5 years to establish this kind of surgery, and I had before a large experience in robotic surgery, more than 8 years. That's why if you want to go in such changing in your daily practice, you have really to plan everything exactly. When we talk about innovations in medicine, the two people as I show you today are really pioneer in the last centuries. On the left side is Mr. Kellett, is a surgeon and anesthesiologist from Denmark. He was the first people ever who was thinking about enhanced recovery after surgery. When they start his program, the patient, when they go, for example, for colorectal surgery, they was in the hospital more than 25 days. And after the implementation, his program, the patient left the hospital after 3 days. The other person on the right side is the Maul Friedrich. He's really a genius. He was also surgeon in a small hospital. And he was talks about the large incision only for the reason that you go in the body. I say something's wrong. What we need large incision before that we can perform surgeries. And there was first his genius ideas to produce TrueCast, small instruments that you can go inside the body. And at this time, the NASA and the US military was making research about robotic system that they can perform surgeries remotely. That means if astronauts, something's happened, they can perform the surgery from the Earth, or also the US military is, for example, in the war in Afghanistan, and maybe soldier, they need surgery, they can perform that from US. And he was looking in this research, and he talked to two friends from him, and they changed to other company, and he created his own company, Intuitive Surgical. It's now more than $100 billion value. That was only with a small idea. It's only 1995, not far away. Both of them are really genius pioneers in the medicine. I will get some slides about ERA's program that you were a little bit in, where we are now. As I said before, Kellert was, his first landmark publication was 1999. And he created the ERAS Society 2010, and the first guideline of perioperative care after radical cystectomy was published 2013. And I think the robotic surgery, especially in complicated cases, they get really profit from this program, because when you go parallel and you were to implement such complicated surgeries, it makes sense that you implement in the same time or before the ERAS program. Now we see 2020, we have more than 22 reviews, 4 meta-analyses, 5 randomized controlled trials. That is now is not more a history, is now is present, it's real, and we use daily. ERAS program, the main key is to look in post-operative changing and to make everything correctly, fluid management, and you look in different pathway of admission for patients. That means pre-admission, pre-operative, intraoperative, post-operative, and post-discharge. You focus on all these steps. There's problem what we see every day in the hospitals. The surgeon, they are focusing only on his part, they thinking only about the surgery. The anesthesiologist, they think only how they can fix the patient during the surgery, and that is really wrong. If you fix in all these points, you will get really the great complications. You will get also length of stay will be increased, and the patient comfort and satisfactions will be higher. And the technical skills, most of people, they say, oh, technical skill is small challenges when I do robotic surgery. No, the other thing, because you see only the peak of the aspect, but the other problems, they are really much complicated. We deal nowadays really with comorbid patients, elderly patients. We have a high desire of good quality of life after surgeries. And that's why you have to check all the perioperative values, and you put in that if the patient, for example, they have problem with the nitrations, you have to fix the nitrations before, and then you can reduce really the complications rate. If you see, for example, for radical cystectomy, the complications rate 30 days after surgeries is really high, 45%. That's what said before. That's normally the thinkings from the surgeons in the last 20 years. Surgeon thinks about the operation, the other things is for him not relevant. But normally, every surgeon has to take interest in all parts: pre-admission, operation, post-operative, and post-surgery. And now we have a good tools, because ERAS Society, they give now teachings program. That means if a center wins or they have a wish to establish or they implement this program, they make for him some training and seminars, and they take all members of team with this program, because you know, if you bring something new in your departments, you have in the first time a lot of people who are against everything. The surgeon, the anesthetist say, I don't need. For me, when you go for minimal invasive, the surgery will take longer. The anesthetist sack, what is about bowel preparation? I don't care about that. That is different thinkings, different conflicts between the different disciplinaries. That's why the ERAS Society, they come in the institution. They say, they make analysis, what is the situation in the hospital, and they go in these details, and they took every team members by side, and they make some conferences, and they'll help fastly to establish this kind of programs. In my experience, and in my opinion, the ERAS is safe, also is in very complicated surgeries. I have now established this program more than 8 years, and we have very good results. You can really improve the outcomes. When I start with cystectomy patient, was at least 15 to 20 days in the hospitals. Now they leave after 5 days the hospital. We don't need any drainage more after also complicated surgery. We have now more educations program for patients. That's mean when they come in the office, they get trainings video. They show how will be the surgery. They know everything. Also, what will be happened in the first 2 weeks after the surgery. They get really educated. We have now in the next time also videos. Telemedicine is coming. That is also the future. That means if you want to plan and successful for us, you have to really get a good structures program. You have to have a strategy. You need also compliance from in your team. Audit is very important. That means if you go in that, you have to plan at least in the first time every 3 months. But with the time you can go for 6 months at least to check how is the results. Where are the problems, and everything has to be in protocol that every members in the team, they know what's happened, what will be the next. Now we will move to robotic surgery. That is the next innovation what we had in the last 20 years. And I have some videos, semi-live videos. They are showing different kind of surgeries. But I think a lot of people of you, they didn't see a robot before. The system is normally, there are 3 components: surgeon console, patient card, and vision card. The name robot is only commercial now because Da Vinci is not a classical robot. It's a telemanipulation system. Telemanipulation system, they mean every movement what I do, they will be transferred one by one. If I move my head from the console, the robot will be stopped. If I move my hand, the robot will be stopped. Everything is controlled by myself. The robot doesn't know nothing. It's completely different than the robot what we know with the hip surgery. They can perform everything by himself. This is only tele-manipulation system. That means they transfers all my Bewegung, my movement into the body from the patient. The history began, what I said before, 1995. This is original picture from the company. This was the first prototype from the robot. Really small idea, small company, one of the richest companies nowadays. This is the first FDA approved system 2000. I get the first surgeries with this system. It was really rigid, but nowadays we have the first generation. We have 2 from this system, and now in the new hospital, in my old hospital, we have 6 from this system. This high definition, no tremor. The Da Vinci company, intuitive company now, the 2019, they developed a new system, ion endoluminal system, to taking biopsy from the lungs. And the last development in the minimal invasive is the single part system. That means you don't need 5 scars to go in the body. It's only in 1 scar you can do all the surgery. You can perform cystectomy, you can perform partial nephrectomy, you can perform all what you want. The milestone, what I said before, 1995 to 2004 was the implementation from the surgeries. The first radical prostatectomy over the world was done in Germany, in Frankfurt, 1999. And the first cystectomy was 2003 done in Egypt with a team from US. And the history from robotic surgery was began by the heart surgeon. The system was normally developed for the heart surgeon, but he was not unhappy with the system. He said the system is nothing, you can put them in the rubbish, it doesn't work. But we know the urology and oral physician and the history, they like innovation. We knew that in the laparoscopy, in the endoscopy, they developed a lot of things. And they saw the machine say, oh, something's great. We can try to make some surgeries with that. And that's why it's normally it was system not fair for urology. What the planning was for the heart surgery, and that's come only by chance to our discipline. That is the systems. The first system in the international market is the Forta system 2003. Now we have the fourth generation 2014 with the XI system. That's mean the main part is free. You can go through the body up down without uptaking from system, and you see the many disciplines now involved in the system: general surgery, urology, cardiothoracic, gynecology, also in the thyroid cancer. Everything now you can do by robot without any problem. But you see also the numbers of robot systems now over the world. We have now in more than 67 countries, more than 7 million surgeries done over the world since 2019, and every 26 seconds will be an surgery by robot performed. The last data from 2020, we see here that only in 1 year the intuitive bought more than 900 systems. Why? Because now the general surgeon, they saw the advantages from system, and they buy now the system in many countries, and we have only last year more than 3,000 articles are published in PubMed to the Da Vinci system. That you can see also in the stock market and in finance. We have only in between 2019 and 2021, the surgical stocks more than triple than the past, because here the general surgeon starting now to using more and more robotic surgery, and here we say small degrees was according to the corona disease, the COVID, but it's not a big deal. Worldwide procedure trends you see here, normally in the past is only from 2015 to 2020. In the past was more procedures done by urology, but now you see the general surgeon are doing more and more procedures. The system implement 2018 at least 1,000 systems, 2019 1,200. Here, according to the COVID, is a little bit regressed to 1,000, but the trend is that more and more systems go engaged to robotic surgery. This is a cohort study from Michigan. This is a collaborate hospital, about 73 hospitals. They start to use robot in 2010. And you see now the trend is now more than 20% of surgeries done by robot. Radical prostatectomy, one of the most surgeries in the urology field. This is data from US. You see it's now more open or laparoscopic prostatectomy more done in US. In NHS now in England is in the guidelines. Every prostate cancer localized have to be done by prostate. It's not allowed more to perform radical prostatectomy open in England. You see how change with innovation, how our practice daily change. How is the situation in Baltic region? In the Baltic states we have only one system. This is not a classical Da Vinci system. This is another system, this laparoscopic base. The Senhance system, they start with the system 2018, the first 100 cases was published then, and now they have now 2 new publications in these years will become 2021. Now they're performing more than 100 gynecological surgeries and 100 prostatectomy with the Senhance system. Only for your information, Senhance system in US, the FDA agreement is not licensed to do prostatectomy with the system. I don't know how is the situation in Litauen that they use the system for radical prostatectomy. What is currently available in the market? The patent from robotic surgery is 2018 was ended, and now we have different kind of systems. Here's a summaries of some of them, and you see here the difference between the systems. Some of them you have controls by finger loops. Some of them are laparoscopic centers, what I said before, Senhens, and important also the instrument diameter. There's now intuitive. They have most of instrument are 8 millimeters instrument, but the single port are 6 millimeter. This is problem for, especially for pediatrics robotic surgery. You need smaller part placement, at least 5 millimeter. This will be also a good mark for the point for other companies. You see here also the use of instruments. Some instruments you can use 10 times. Some instruments are unlimited. But the intuitive company now, they know this problem, and they are now changing his idea, because in the past there was only monopoly. That means everything was controlled by them and it was fixed by them. But now they have no concurrence. That's why since this year, for example, needle holder, you can use them at least 15 times. Scissor by 10 times. Other instrument you can use them till 20 times. That means that the intuitive company now they are changing some details in her philosophy, because they have to change. They have now also we know now Google. They are planning now a huge program. I was also associated in trainings program. They was connecting us in my department. He was controlling every movement what we do during the surgery, because they are thinking now about self-doing surgery, like artificial intelligence, but that will be the future. Also, to complement the system, there's another systems. Japan will bring also another system. China, they have also a robot now. This on market. That's mean in the next 10 years, we're sure that we will have at least 10 systems. They are in the good quality, like intuitive company. This is only some picture from different systems that you get a little bit idea. That is the Revive surgical robot. This is from Cambridge Institute in England. Versus surgical robot system is not placed according to this mean. You can put the system where you want in the OR. And the Senhens robot system, what is in Litauen, that what they said is laparoscopic based. This is not finger loops based, and that is the single part system from Boston Scientific. The OR also in robotic surgery is completely different than what we know from open surgery. You need a lot of screens. Why? Because when we get guests from other department, or some teams, when they start with robotic surgery, and they come to us in our hospital, and they see a lot of monitors. Say why? Because everybody have to be involved during the surgery. What are you doing like a surgeon? Because when you sit in your console and you are performing surgery, the patient is a little bit far away from you, and everybody have to know what are you doing. If you get bleeding, you have your team. They have to get for convention. If you need some sutures, your team have to be prepared. That's also the surgery will be faster and everything will be good. The next slides will be the first semi-life surgery. This is a lady with bladder, muscle invasive bladder cancer. I performed for her robot-assisted radical cystectomy with neo bladder formation, and vaginal wall sparing. So you see in the right side, this is ureter, and you see the assistant now are clipping the ureter. That is frozen specimen for the pathologist. Now are opening the vagina. That's what we see down is the manipulator. Now we go from the other side to prepare also the ureter from the other side. And you see how it's clear the anatomy. How is this also? You don't have any tremor. What normally usual what you see by laparoscopic surgery. Is the vaginal wall, the anterior vaginal wall, and you can spread all fat and all structure from the vagina. Then you can go from preparing the urethra, the bladder go down. Here is the bladder neck, here is the urethra, and you see how it's good to define the stump of urethra. Normally in open surgery, everything is very deep and small in the pelvis. You have any the control of the structure. If you go, for example, for nerve sparing, you can see that with your eyes, but by the robot you have really clear what you are doing all the time. This is lymph node removal, and then we go for the reconstructive part. Specimen will be removed through the vagina. Now the ureter will be passed to the other side under the sigma. Closure of the vagina. The next step will be the anastomosis from the intestine to the urethra, and here you see how precise you can go with the continuous suture to between the intestine and the stump from the urethra. And was one of the biggest challenges in the open surgery of when you perform a radical cystectomy. You have at least 50% leakage after anastomosis, but with the robot you have less than 1% that you have really leak after cystectomy or prostatectomy, because you can see better. You have the instrument, they are only 1 centimeter. Your hand is at least 7 to 8 centimeter. That means you can't go behind the bone, but with the instrument, in 1 centimeter instrument, you can go in every area you want. And also all instruments, they are 0 grade of freedom. That means you can turn what you want in which angle you want. Because the next innovation in the minimal invasive surgery is the intracorporeal diversion. That means you can perform neobladder inside the body without that you open the wall. This is with smart clap technique. That means when you go with stapler, the stapler, they give you a feedback. That means there is enough power under the intestine, and then you can go for firing. Now you go for side to side anastomosis. You see here what I said before, robotic surgery is a work team. That means the assistants outside, you have to know when they have to put his instrument. You sit here and then strain down. that the feedback from stapler are saying to you, is there enough power, and then you can go for firing. That means if you don't have power, the system, they don't close. That's at the end of the day, you have less also anastomosis leaks, intestinal anastomosis leaks. That is also one of the big problems if you perform intracorporal cystectomies. The next step will be the closure, the neobladder, and then the surgery is done. Another point was the next surgery will be radical prostatectomy. Why radical prostatectomy nowadays done by robot according to all the structures? Because we know we have now better diagnosis. That's mean much young people, 40, 45, maybe 50 will be diagnosed by prostate cancer, and we know that's really important nerve structures. They go behind and lateral from the prostate, and all this structure you can't save by open. This is only 2-3 millimeter. This is the neurovascular bundle. But when you perform the surgery robotically, you see all these nerves, and you can't preserve this nerves. It's also nowadays it's not question of cancer-free. It's also a question of quality of life. Patient, they want to be after surgery dry. They want to be part-free, and they want to be potent. That's why the goal of us not only the patient get him cancer-free, but also with good functional results. Another challenges, cases and innovation of robot surgery. This patient was operated open with LU neobladder segment, and he get uretero-neobladder anastomosis structures, and that's mean all the intestines are damaged, but you can use during the surgery what we call fluorescence technique, indocyanine green. You put it in the bladder, in the neobladder, and you can see that's neobladder, that is normal intestine, and then you can go in your preparation. See here all the time you have what we call in robotic surgery tile pro technique. That's, you have special pedals, and you can see during the surgery which structure is with good blood supply and which structure under. See here the preparation from the vessels, from the ureter. Normally, ureter, when you take in your hand, is less than 3 millimeter. What we see here in like a huge organ. Now you can go for closing the defect from neobladder, and then you go again for new anastomosis between the ureter and neobladder. That's really very, very challenges surgery. You can then perform only in high expert center, because if the patient come to you and they are suffering, they are young and they are all the time using tube to drain the ureter, and they want to get after that without ureter, without drain, and if you don't carry out, you don't have any experience, maybe you damage the intestine, and they go after the surgery not with only drain from the catheter, they get done with stoma, with stool stoma, and with drain, and then you make patient unhappy. That's why you have to know also your experience. You have to go when you have to know when you go for surgery, when you say also not. It's only docking from robota. Then we get the next short video is that you see also how anatomy is clear. This is a lady with after failure of vaginopexy. The surgery was done by gynecologist in the vaginal on laparoscopic route, and she came to me with recurrence totally prolapse, and you see here the alt mesh, and the surgery that, will start with preparation, the space between the arteria iliaca interna and the promontorium that you get normally in fatty vessels free space, and you see here this promontorium and the vessels in the air from the promontory. This is also one of the advantages. Many ladies, when they get, for example, prolapse surgery repair, and they done the surgery open, there are some nerves in the nerve from the artery, and then you can, when you put your suture, you can suture also the nerve, and the patient, they develop with the time chronic pelvic pain. You see how it's clear that you can prepare every structure, you can see everything what you do. And you see also again the traction from your assistant. Robotic surgery is traction surgery. If you don't have a good assistant by side, it's normal prostatectomy, they take you normally 1/2 hour, but if you have assistant, they don't have any experience, they can take you 4 hours. That you know. For example, cystectomy intracorporal by robot, they take you 5 hours. If you have an experienced assistant, they take you 8 hours. It's an experienced hand. This is assistant. That's why we get a lot of trainings for our assistants. We make a lot of video sessions. All surgeries in our department are recorded. That means if also some complications happen, you can go in and you can see what's happened with surgeries. For example, for my training, when they perform, for example, prostatectomy, and they have some problem, I come to OR and I say, okay, what's happened? I can make the video shortly back and I can check what's happened, and you can fix them. This is also another advantage of robotics. This is the past video show you only how you perform, for example, anastomosis after radical prostatectomy. And you see also how it's clear the stump from the urethra. Neurovascular bundle, urethra, pelvis, bladder. Bladder neck, bladder opening. The spark suture, that means the suture, they have small field in the side. That means the suture can fix in, that they can't move by himself. The bladder will be put down to the small pelvis. And you see all the time the assistant are cleaning the field, that they can see everything is clear. The surgeon, they are happy. The assistant, they know when they have to wash, when they have to suck. There are also many training centers in Europe. Now we have 4 training centers, 2 in Belgium, 1 in France, and 1 in Luxembourg. The future might be that the anastomosis will be done completely robotically. That's why Google now have a big program that some steps of the surgeries, especially the steps who they don't need visual control, maybe it will be done completely robotically and not what we know now with telemedicine. That will be the future. But I am sure maybe in the next 10 years, different steps of the surgery will be done completely robotic, but only some steps will be done by surgeons. See here the bladder go down and the anastomosis will be fixed. So, this is partial nephrectomy. Yes, also you can do partial nephrectomy by robot. That's ureter, vena cava. You can secure the vessels with a vessel loop. That's mean if something's happened, a patient get bleeding, you can go ahead for conversion without any problem. Especially if you have by side of you patient, a colleague who didn't have a large experience, you have to fix everything like this. But normally, if you have experts team, you don't need to make these steps in the surgery. And now you clean the fat over the kidney. And this one is also another tools of robotic surgery. That means you can perform ultrasonography during the surgery, and you can see in your screen, this is ultrasound, and you can see precisely during the surgery with the ultrasound the margins from tumor, and then you can really resect only the tumor. There's an upper pole tumor about 3 centimeters, and you can go through the tumor, and then you save really branch time. And we know in how it's important that to save every tissue from the kidney. That was a small talk about innovation in medicine, especially in urology. And I saw some young people here in the room. I'm happy that they are also here. That if you believe in some things, you have to go in. If you stay in one institution and you see that you are unhappy with the situation, and you know maybe in the next place is maybe better for you, then you have to change. Because innovations nowadays is very, very important. I know when I see the title of the conference, I say it's really very precise title, and I like them, but I know one world, one health is not easy, because every country they have sources, there are governments, there are money problem, you have payers, you have healthcare, and but I think in the next years, especially, for example, when I think about Germany, because I know the situation in Germany, is no place more for open surgeries. They are now, and only in the last 20 years, more than 30% of urology departments are closed. Only in the region when I walk, is more than 10 urology departments are also closed. They don't, also the small urology department, they don't do any cancer surgery more. They will be everything with the time only in the centers, because the results, we saw the functional results, and also the office doctor, when they walk in the office, they don't want to get any complications after surgeries, because they know if I have a patient with complications, they have to come to me every second week, and I have to deal with him, and I have to take to them. That's why they send patients only to the reference center. We have internet, you have rating scala. Patients, when they come to you now in the hospital, the first question they ask you, how many surgery have you done before? Do you have any experience with robot? If you have only a robot and you didn't teach your team, you will be fired. There are also money example is in Germany, money institution, they have robot, but after 1 year they gave them back, because the they was thinking I have to train only the surgeon. I don't need to train all my team. And with a surgeon, doesn't work. And I hope that you enjoy the urology and the robotic surgery in the urology. Maybe in the future, one of you will be also a robotic surgeon. Thank you.
Thank you very much for your presentation, which highlighted the real future of non-invasive surgery. It's of course, you have also mentioned some reimbursement problem. I guess it's also one of important not only in Germany but also in future in our country. Are there any questions from the audience?
Thank you so much, Mustafa, for very comprehensive covering of this complicated topic. It was very practical and very scientific. Thank you very much. And my question is, could you mention some absolute contraindications for robotic assisted approach to urological surgery?
Normally, nowadays is no contraindications for robotic surgery. But if the patient have maybe a history of complicated general surgery with stoma, with intestine perforation, and you can't place the trocar, then this is a relative contraindication for robotic surgery. But in generally, it's only one contraindication from Tendelenburg, not for robotic surgery. It doesn't matter if you make the surgery laparoscopic or robot-assisted, it's the Tendelenburg position. If the patient are suffering from lung disease and the VEF, you don't know what VEF means, the 1 second capacity from the lung is less than 60% is relative contraindicated, if less than 40% is contraindicated. Because nowadays, when I start with robotic surgery, we make the capnopenetratum, that's mean the CO2 inside the body was by 12 to 14. But now we decrease the capnopenetratum to 4 and 5. This means I can perform robotic surgery with only a capnopenetratum with 4 or 5. In the other side, that means there's also patients nowadays with less pulmonary fraction. If the patient with the complications, he said, okay, if I get complication, then you can go for that. But the only absolute contraindication is the pulmonary function. If the 1 second capacity lasts than 60%. Patient with glaucoma is also not complicated by the heavy contrast during the surgery. That means patient, if they have a history from glaucoma and the pressure is higher than 22, they have to go before the surgery, they have to get here medication. And I don't put him severe in 30 degrees, only in 20. And that's also not a problem. Also, but they say to this patient, kind of patient, they have to go center with experience, because every minute surgery is time and time consuming for him. That's been the surgery. If you go for robotic surgery, you have to go at center, that the surgery will be done really fast. Because if you are, for example, some center they are doing now prostatectomy 5 hours because they are in the learning school. But you go in an expert center, they do prostatectomy in 1 hour. And that's make change if you perform surgery 1 or 5 hours, and you put the patient like this with glaucoma. That is some relative contraindication, but absolute contraindication is only what I said before, the pulmonary function.
Thank you so much.
Thank you for a brilliant lecture. I have also one question, and we all know that our world suffers with COVID pandemic. And what you can say, how is possible to protect these new challenges, for example, this Google system, this these possibilities with artificial intelligence from viruses?
Very, very interesting question, but also the answer is very complicated because we know that in the time from COVID, the only company who gets really, especially in surgery field, who get, although despite the problem from COVID, benefit is intuitive, because the problem in the COVID time was the intermediate care. You didn't have enough places in the intermediate care. And when in my hospital, we perform all surgeries we don't stop any program, because we select the patient, because we know that after surgery, robotic surgery is not the possibility that the patient go to the intermediate care, intensive care is very, very low. That's why the government has allowed to perform the surgeries. But a lot of hospitals, they don't have, for example, minimal invasive surgery, they close all the departments. That's why also in the time from COVID was really beneficial if at center have robot and they have also experience with minimal invasive surgery, because they was allowed to perform surgeries without problem. That was the same not only in Germany, in UK, but was also possible only patient in center, reference center, they have experience with robot surgery, they can perform, although in the main time from COVID was allowed to perform robotic surgery.
Thank you.
Okay, thank you very much for your presentation. We will proceed further. I would like to welcome next Christoph Folkmanis for a lecture about the new personalized treatments.
Difficult to perform my presentation after this brilliant previous presentation, but I'll do my best. I'll try to my best. Hello. First of all, I'm glad that in this strange and unpredictable time we are all able to meet on-site conference. I bet all of us have been waiting for it for such a long way of time. As you noticed, the main topic of today is novelty in the development up-to-date medicine. My presentation won't be any different. I will tell you about immune cancer therapy in the means of checkpoint inhibition, in personalized therapy of prostate cancer or bladder cancer and of renal cell carcinoma. As already I mentioned, my name is Christoph Folkmanis. I'm working in Siegen in the same institution as my chief, Dr. Adali, and at the same time I'm a lecturer at the University of Latvia. I jot down for you also my email, so if you have any questions or remarks after this presentation, you can contact me per email communication. For this brief review, we will have approximately half an hour time. Within this time, we will discuss the history of immune checkpoint blockade and its role in bladder cancer, in prostate cancer, and in renal cell carcinoma. Additionally, I will demonstrate you an original research study that we made here in Latvian University within the time of last 4 years. In the relation of theme, DNA mismatch repair protein expression in prostate cancer. The aim of this review is to provide a summary of current state of the art of immune therapy as potential treatment of various tumor entities, particularly in relation of prostate cancer, urinary bladder cancer, and kidney cancer. The hypothesis the next 20 years in up-to-date medicine belong to checkpoint inhibitor era. After this presentation, every single of you will be able to decline or accept this hypothesis, this affirmation. Introduction. Early detection of cancer followed by personalized approach to therapy is a key factor of up-to-date medicine. This actual time is, as I already mentioned, strange and unpredictable. This comparison can be made not only due to actual coronavirus situation, but also the same can be noticed in personalized medicine by means of checkpoint inhibitors. The old dogmas, for instance, chemotherapy or metastasis surgery, are being appended with new diagnostic and therapy use of checkpoint inhibitors. What exactly is checkpoint blockade and how it is working in 3 tumor modalities, bladder cancer, prostate cancer, and renal cell carcinoma? This review will provide a brief and detailed guideline-compliant outline. Immune checkpoints are normal parts of immune system. Remember, this is normal part of immune system, which prevent an immune response from being so strong that it destroys healthy cells in the body. However, they can be used by cancer cells to hide the tumor from immune cells, especially T cells, and prevent the immune system from destroying the cancer. Checkpoint inhibition therapy is a form of cancer immune therapy. It's contrary to chemotherapy. It's contrary to cytostatic therapy. It's immune tumor therapy. The therapy targets are immune checkpoints. Checkpoint inhibition therapy block inhibitory checkpoints, restoring immune system function. The first checkpoint inhibitor was ipilimumab, a cytostatic T-lymphocyte antigen 4 blocker, approved in the United States in 2011. Currently approved checkpoint inhibitor targets the molecules cytostatic T, lymphocyte antigen 4, programmed cell death antigen 1, and programmed cell death antigen ligand 1. PD1 is a transmembrane programmed cell death 1 protein which interacts with its ligand. PD-L1 key function is regulatory role of T cell activities. Checkpoint inhibition allows the T cells to attack the tumor. Checkpoint inhibition targeting either PD-1 receptor or its ligand were first approved by Food Drug Administration for the management of metastatic melanoma in 2011. Professor James Alliston, Professor Honjo won Nobel Prize of Medicine in 2018 for their involvement in checkpoint inhibitor research. And now let's see our next topic, role of checkpoint blockade in bladder cancer. Systematic therapy for bladder cancer is used either perioperatively with curative intent or as palliative setting. Currently, only chemotherapy is considered as a system therapy for perioperative use. The inclusion criteria of patients' compliance for chemotherapy are performance status and renal function. Performance status nil till 1 and glomerular filtration ratio more than 60 ml per minute allow apply chemotherapy. If GFR is less than 60 ml per minute and performance status is more than 2 points, means that cisplatin should no longer be used, and immune checkpoint blockade enters in the first line therapy setting in this indication. In the second line setting, the place of immune blockade is already granted. Prerequisite for the use of immunotherapy, for example, pembrolizumab with its keynote inclusion study, or atezolizumab with its IMvigor approval study, is positive PD-L1 status of patient. In second line therapy, immunotherapy with pembrolizumab should be carried out. Alternatively, atezolizumab or nivolumab with its checkmate inclusion study could be used. The difference of the level of recommendation is due to the level of evidence, since data from a phase 3 study are only available for pembro. In this chart is represented the aforesaid data. First of all, let's pay attention to eligibility criteria for cisplatin-based chemotherapy. Performance status and renal function are the key factors. By the way, it's pretty simple. You see, if a patient has performance status more than 2 and GFR is less than 16 milliliter per minute, instead of cisplatin-based chemotherapy, you should apply for the patient checkpoint inhibition therapy, either pembrolizumab or atezolizumab. For both of them, PD-L1 status is mandatory. But in the second line section, the PD-L1 status play no role at all. That means you can apply one of the 3 checkpoint inhibitors, either pembro or atezolizumab or nivolumab in this therapy setting. First option is given to pembro, as keynote approval study was the only phase 3 inclusion study. Let's remember, IMvigor study for atezolizumab and checkmate inclusion study for nivolumab are phase 2 studies only. In this slide I have jotted down for you the dosage and application regime for commonly used checkpoint inhibitors as pure matter of interest. That means if you aren't clinician practicing your daily routine with tumor immunotherapy, you are not obliged to remember the exact dosage and application scheme. What is important for single of us are the possible commonly seen adverse reactions, and for checkpoint inhibitors they are cough, pruritus, diarrhea, fatigue, nasopharyngitis. In the following chart, you see the landscape of prostate carcinoma development. First of all, prostate carcinoma is slowly developing tumor entity. Secondly, its character is kind of interesting, as at the very beginning, it appears to be hormone sensible, but afterwards, in advanced stage, it remains hormone resistant or so-called castration resistant. In the following couple of slides, we will discuss the peculiarity in dividing prostate carcinoma in 2 groups: in metastatic hormone sensible prostate carcinoma and in metastatic castration resistant prostate carcinoma, with consequences to appropriate therapy setting. First of all, therapy of metastatic hormone sensitive prostate carcinoma. Androgen deprivation therapy is recommended to all patients in this phase of disease. Patients with a good general condition must be offered additional chemotherapy with docetaxel or further secondary hormone manipulation. A subgroup analysis of charted data. Charted was inclusion trial for docetaxel-based chemotherapy for metastatic hormone-sensitive prostate carcinoma. Data demonstrated that patients with high tumor burden, defined as the presence of visceral metastasis or more as 4 bone metastases outside pelvis region, benefit from chemotherapy. Cyproteran acetate 17 inhibitor abiraterone in combination with androgen deprivation therapy was analyzed in approval studies Latitude and STEMTATE trials. The results of enzalutamide with its inclusion ENZAMET study and apalutamide with its inclusion TITAN study correspond new generation androgen receptor inhibitors for treatment of metastatic hormone-sensible prostate carcinoma. By looking at this table, firstly, you should pay attention to endpoints of both of the trials. For use of enzalutamide, it is 3-year overall survival advantage of 80% for patients in comparison with only 72% overall survival advantage for standard of care group, respectively for chemotherapy. For use of apalutamide, it is 2-year overall survival advantage of 84% of patients in comparison with only 74% overall survival advantage for patients in placebo group. And now let's move to next division of advanced prostate carcinoma, respectively to castration-resistant prostate carcinoma. According to definition, laboratory findings in castrate state must consider serum testosterone level less than 50 nanogram per deciliter plus 3 consecutive rise in PSA value, or an alternative, a radiological progression should be noticed. For example, in the means of new lesions, either 2 or more new bone lesions or a visceral lesion. And now therapy of metastatic castration-resistant prostate carcinoma. Androgen deprivation therapy plus abiraterone with its inclusion co-trial, or enzalutamide or docetaxel with its inclusion tax trial, are state-of-the-art in this particular tumor division, respectively in an advanced state of tumor. Serious side effects of abiraterone include heart disease, elevated liver enzymes, and hypertension. For enzalutamide, with its approval study Prevail trial, it is an androgen receptor inhibitor and blocks the shift of androgen receptor into nucleus as well as DNA binding. Relevant side effects of enzalutamide are memory impairment, hypertension, and fatigue. That means if I will become, if I will receive a patient with Parkinson's disease or memory impairment or loss, I won't, at any case, prescribe for such a patient enzalutamide in metastatic castration-resistant prostate carcinoma stadium. Relevant side effects of docetaxel therapy include alopecia, fatigue, and neutropenia. Standard dosage are 3-week regimen with 75 milligram per body surface area, with altogether 10 cycles of therapy. The radionuclide therapy also plays an important role in this indication status. It represents the first and second line treatment option in metastatic castration-resistant prostate carcinoma without concurrent visceral metastasis. That's the only indication, without visceral metastasis. There can be as many bone lesions as possible, but there should be no visceral metastasis. Typical adverse reactions are neutropenias, thrombocytopenias, or diarrhea. And now molecular diagnostics. All metastatic patients should be offered somatic genomic testing. I bet that will be more explained within the next presentation by Professor Caesars, but short introduction will I already within this presentation give you. This testing is applicable for DNA mismatch repair deficiency. Mismatch repair deficiency assessment can be performed by immunohistochemistry for mismatch repair proteins and or by next generation sequencing assays. Germline testing for breast cancer, 1 or 2 antigens, ataxia telangiectase mutation, or mismatch repair status is recommended for high risk and particularly for metastatic prostate carcinoma. Microsatellite instability and or mismatch repair deficiency is a rare condition in prostate cancer, but for those patients, pembrolizumab has been approved by Food Drug Administration and could be a valuable additional treatment option. Use of polyadenosine diphosphate ribose polymerase inhibitors, for example, olaparib, with its approval PROFOUND study in patients with metastatic castration-resistant prostate carcinoma and mutations in DNA repair genes, is approved for this indication. The recommended olaparib dose is 600 mg daily, taken orally. Common side effects of olaparib are nausea, vomiting, neutropenia. As another alternative sequence after therapy with docetaxel and 1 line of hormone treatment for metastatic castration-resistant prostate carcinoma counts checkpoint inhibitor pembrolizumab. It was approved by Food Drug Administration for all mismatch repair deficient cancers and or in those with microsatellite instability. And now, take a look of original research study that was made in Latvijas University within last of 4 years in relation of the theme DNA mismatch repair deficiency in prostate carcinoma. Our aim was to evaluate and compare the expression of exosomal biomarkers and DNA mismatch repair biomarkers in the tissue of patients with benign prostatic hyperplasia and prostate carcinoma. Or methods. The study was retrospective. Altogether, 92 patients with prostate carcinoma and 20 patients with benign prostatic hyperplasia were enrolled in the study. Exosomal DNA repair biomarker expression was analyzed by immunohistochemistry. Follow for each patient in the study lasted till disease progression and or maximum 5 years. When all the patients were analyzed together, the tendency of increased CD63 expression was observed in patients with prostate carcinoma. When low and high-grade patients were independently analyzed, the CD63 expression was significantly higher in patients with high-grade prostate carcinoma than low-grade prostate carcinoma. Here you see correlation between prostate carcinoma grade groups and CD63 expression score. The median progression-free survival was significantly longer in patients with low CD63 expression compared to high CD63 expression. CD9 expression was significantly decreased in prostate carcinoma compared to benign prostate hyperplasia. The median progression-free survival in patients with high CD9 expression was significantly longer compared to patients with low CD9 expression. This chart shows negative correlation between prostate carcinoma grade groups and CD9 expression score. The median progression-free survival with DNA mismatch repair deficiency was significantly shorter compared to patients with preserved DNA mismatch repair expression, respectively 22 compared to 16 months. Conclusion. The immunohistochemistry expression of CD63 and CD9 is different in patients with prostate carcinoma compared to patients with benign prostate hyperplasia. Immunohistochemical CD63 expression is closely related to prostate carcinoma World Health Organization 2016 grade group gradation. Progression-free survival in patients with DNA mismatch repair deficiency was significantly shorter than in patients with maintained DNA mismatch repair expression. CD63 overexpression as well as reduced CD9 expression was a characteristic for shorter prostate carcinoma progression-free survival. Apart from cytokines, okay, and now let's move to our last topic, to role of checkpoint blockade in metastatic renal cell carcinoma. Apart from cytokine therapy, interferon alpha and interleukin-2, which is ancient, a lot of therapy options are available in nowadays medicine for metastatic renal cell carcinoma. Firstly, they are tyrosine kinase inhibitors. Secondly, they are mTOR inhibitors, for example, everolimus. Thirdly, they are vascular endothelial growth factor antibodies, for example, bevacizumab. And the newest therapy modality, of course, are checkpoint inhibitors. For example, PD-1 inhibitors, PD-L1 inhibitors, and cytostatic T lymphocyte antigen 4 inhibitors. Here you see the whole landscape of metastatic renal cell carcinoma therapy setting and treatment options within last decade. And therefore, open remains the question, which particular drug should we applicate for specific patient subgroup? The right answer guarantee you metastatic renal cell carcinoma prognosis groups. Two of the broadly used of them are Mozart score and Henk score. They are both pretty the same, with a slight difference in laboratory necessary parameters of patients. Mozart score considers such laboratory parameters as hemoglobin, lactate dehydrogenase, and calcium. Henk score considers instead of lactate dehydrogenase, neutrophil granulocytes and platelets. Both of these scores consider general condition and time from disease to diagnosis to metastasis as evaluation parameters for score. Every single abnormal parameter gives 1 point. The sum of the points represents in terms of overall survival whether the patient belongs to good, to intermediate, or to poor prognosis group. Regarding to this aforesaid division to prognosis groups is also different which kind of therapy we will recommend the patient. The following chart shows you this differentiation. As you all see, depending on the prognosis group, realize the choice of appropriate therapy setting. For example, for a good prognosis group, first-line setting, application belongs to combi therapy, to pembro and axitinib. Pembro is a checkpoint inhibitor, axitinib is a tyrosine kinase inhibitor. For poor and intermediate prognosis group, also you can applicate the same combi therapy setting with the addition of another combi therapy setting containing two checkpoint inhibitors, ipilimumab and nivolumab. With an appropriate dosage, as already mentioned, I won't go more deeply in details. And now, conclusion. Checkpoint inhibition is collective name used to describe molecules from drug class that targets adaptive immune suppression pathways. Checkpoint inhibition are now used in personalized treatment for bladder cancer, for renal cancer, for prostate carcinoma. Finding a predictive biomarker of outcome for checkpoint inhibitors has been a topic for research for the last few years. As a result, today there is a wide variety of such biomarkers of different types: PD-L1, PD-1 expression, mismatch repair deficiency status, and microsatellite instability. Take-to-home message or FATSIT. Use the expression of aforesaid biomarkers to guide decision-making about prescription of checkpoint inhibitor therapy. Thank you for attention, and as you see, Golden Bridge in California have every single time a fog above us, and the same characteristic we could describe in our research matter of system. We should every single time look ahead of us. Thank you.
Thank you very much for your presentation, which highlighted not only current trends and perspectives, but also real future guidelines for the treatment. So any questions on the floor? It's open for discussion.
Thank you for this presentation. Did I get right that nowadays checkpoint inhibitors we use more or less for metastatic tumors? Or I'm not right?
You are completely right. The first indication setting was for pembro, for pembrolizumab, for all metastatic tumorous entities with with proved PD-L1 status. The organ plays no matter at all, whether it's prostate or gastric carcinoma or melanoma. If it's metastasis and it has this microsatellite instability, respectively mismature PR protein deficiency in terms of PD-L positive status, you can applicate this way of therapy.
Thank you for the presentation and really large work. I think this is huge information. Problem what I see in this kind of treatment checkpoint inhibitors, that's how you can use in your daily practice, because you give us here a huge number of medications. And what I see in my daily practice, especially of diagnosis, when we get the PD-L status, sometimes I need that after testictomy, and you send them to the pathologist, you get another result, and you send them to the next center. Maybe in one center is positive, the another center they say you is negative, and that's normally have to give you some information, then you can make decision for which kind of treatment you will go. But if you get different information and different results, then that's big challenges in the future. And the FDA, this is another problem what I say. The FDA they said you can use this kind of treatments without testing. That means scientifically is completely wrong. But if the ASA is not a problem, we can use the medication. I don't know how is the situation in Latvia. If you have certified pathologist center, they give you results, or is not certified center here?
Dear Mustafa, thank you for this good remark, and yeah, you paid a lot of attention to my presentation, because it is for sure the matter of interest how and with which criteria we should applicate this way of therapy, because in prostate carcinoma only 10% of prostate carcinoma cases are with microsatellite instability and mismature PR protein deficiency, and in such cases you could say that the immune checkpoint blockade really shows a good result. I think the essence, the backbone of successful therapy and treatment application is good cooperation with your pathological department. I have such a luxus to have such good pathological professor as Professor Isaias on my side. He will also in his next presentation will also give you some brief outline about the theme, but pathologist plays enorm big role in this kind of patient selections, and what we saw in our original research within the last 4 years, also with kind of simple methods. For example, with immunohistochemistry, you can get relatively good double-blinded answers, very reliable answers, and they correlate also with the clinical situation of such patients. Thank you.
Thank you very much. I can just add, yes, this multifunctional communication and this team between clinicians and pathologists is very important, and especially for this personalized treatment. As for PD-L1, it's sometimes it's not so easy. For different tumor locations, you have different testing approaches. You have different also cutoff. What is positive? What is really negative? And second problem, you have different testing panel and different treatment who can act PD-L1. For example, it's very like a good example for lung cancer. We have two different medical treatment. One is from Merck MSD, one is from Roche, and each require a different testing system to be applied. So sometimes it's not so easy, and each laboratory which participated in such testing should be certified and have accreditation to perform this testing, and especially a laboratory should have a good internal and external quality assurance and control, because it's one of potential requirement for laboratory. But you're right, sometimes yes, you could have false positive or false negative results. Such situation is present also with Latvia, but to improve our testing capacity, we try to perform control testing, both positive and negative control, to be sure that this testing is actual and information which is provided to clinician could be used and could be used appropriate. Okay, if there is no questions about this presentation, thank you again, and we will continue a topic about tumor pathology and personalized diagnostic. The problem about malignant tumor diagnostic is very important, since we have a global increase in cancer incidence rate and mortality. And secondly, we have a lot of patients in which a tumor is diagnosed in advanced stage. It's stage 3, stage 4, when the treatment is not very efficient, and therefore we need for real good tumor biomarkers and good tumor personalized treatment. It's very important that not only in the modern 21st century we would like to have a good tumor diagnostic. If we are dealing from the history, how to discover the tumor and what it is the real situation, where people have been interested also in ancient Egypt, we have found from the history. Of course, during development of anatomy, and also from in case of anatomy, Da Vinci, we have comprehensive knowledge of anatomy, but still the pathology discovery in the tumor diagnostic only with the 17th century, when the microscopes have been established. Before this time we don't really know from what is the real tumor. Next is 19th century, it's Rudolf Virchow, who acts that the tumor develops from the cell. And of course, which is very important for tumor biomarkers and for diagnostic, of course, this is tumor genetical testing, and the knowledge that tumor develops due to a specific genetic mutation. There are a lot of genes in the humans, it's more than 20,000, and how we can know which real gene is responsible for this tumor development for metastatic potential, especially for treatment. And where is very important not only communication between clinicians, pathologists, but also informational technology. If we don't have the techniques who can analyze the specimen, who could not provide comprehensive knowledge and comprehensive analysis, it is impossible to make a correct diagnosis and appropriate treatment. So, due to the significant development of informational technologies and artificial intelligence, we have a possibility to evaluate the tumor changes in the response of whole genome and whole protein expression. So, the tumor, if we look at the tumor, it develops due to a different type of mutation, which could be germline, if it's developed in the germ cell, or somatic, if it's developed in other cells. And tumors mostly influenced by so-called epigenetic alteration, which is affected DNA and protein conformation. How we could diagnose the tumors? Of course, it's important to have specific tissue samples, which is obtained either by biopsy or by surgical material, or by liquid biopsy, by which I will have next presentation. So the classical diagnostic methods of tumor is by H&E staining, this is hematoxylin eosin, by which we can prove the tumors. We apply subsequently immunohistochemistry, which is important for tumor diagnostic and for discovery of biomarkers. We have genetic mutation testing by in situ hybridization, which revealed specific changes in the cells, specific protein, mutated protein. And to look deep in the tumor specific development mechanisms, we have polymerase chain reaction, PCR, which act on one specific tumor gene, for example, which is responsible for tumor development. For example, one of the important genes in melanoma development is BRAF gene. There is significant correlation of genetic mutation and tumor, how tumors look like clinically and histologically. For example, a specific melanoma gene mutation, BRAF mutation, present in nodular melanoma, which looks in a patient like nodule and histology. So genetic markers and genetic specific changes very well correlate with clinical findings and with histological features. One of potential problems, as also has stressed out by some previous questions, how what could we do if we have different laboratory testing system and also different technicians, different pathologists, different genetic, different laboratory. So how we can standardize those processes? And here we have so-called digital pathology and artificial intelligence, which use specific machine learning and deep learning techniques, which can analyze by standard techniques different changes not only in tissue but also in regardless clinical information and genetic mutation, and put it all one together. And due to this analysis, we can skip many problems and many errors which is present if the samples are analyzed by individual, for example, pathologists, because we have so-called inter-observable variability, and the artificial intelligence help us to skip it. So how it's seen in real life? We have specific digital scanner which scan the slides. When it has been digitalized, by artificial intelligence, the program skip where is tumor and mark the tumor cell is in one color, benign tissue in another color, and then calculate how many the tumor cells are present, how many specific biomarkers are expressed, so and if it's positive or negative. Because for a personalized assessment, for example, PD-L1 expression, to analyze is it positive or negative, you should reach cutoff of cell positivity. So how many cells are stained, and based on this, it's just is it positive or negative. In pathologists, we have inter-observable variability to assess. By if we digitalize and scan the slide and do it by artificial intelligence, by machine learning, we skip inter-observable variability up to 60%. So it's quite very good results. For example, what we are started to do also in Latvia, we start a pilot project with prostate cancer assessment, since in the biopsy it's also the high variability assessment, for example, in Gleason score between the pathology, and how to standardize this assessment. So by machine, the tumor tissue are digitalized and assessed all the structures by machine and calculate tumor percentages, and created by digital analysis and shows the structure in specific color, it's helped to assess the percentage of tumor and to calculate the specific amount of tumor cells. It reduces errors in the diagnostic up to 50%, so it's with very potential used in the clinical practice. And of course, this is very important also for patient management and the guidelines. If we are dealing with malignant tumors, malignant tumors are characterized by mostly different type of mutations. So there is more than 100 mutations in tumor cells. However, the specific markers for which we could have diagnostic assays are just less than 50. So very small diagnostic assays we have at the moment, and also the personalized treatment, so which could act on these specific genes, also at the moment is not very high. But the assessment of those markers, it's represented one of the potential direction of personalized treatment. So when we aimed on the specific tumor biomarkers, and if we look during the last 10 years, the number of those biomarkers and the testing assays is increased. So what are those biomarkers, and by which techniques we used to analyze those markers? First of all, the novel methods which is available to have and to discover those markers in the cells is so-called NGS, next generation sequencing. This is methods which allowed from tissue samples to discover and to analyze different both somatic and genetic and germline mutation, and also epigenetic changes. We can discover what kind of mutation are present in the cells, and it is based on a subsequent decision of the treatment guidelines. However, not always it's possible to have the sample from the patients. For example, in patients with lung cancer, when the tumor is very in advanced stages, it's up to 10% when the biopsy, to obtain the biopsy is very difficult from the clinical point of view. And we have last 5 years one field which is very subsequently with a great perspective, so-called liquid biopsy. So liquid biopsy, it means that in different types of liquids, the source could be different. It could be blood, it could be urine, it could be cerebrous, it could be saliva, so the source could be different. The most important one, which have used, of course, this is saliva samples, this is urine samples, this is plasma samples, and the idea for the liquid biopsy is the tumor cells produce substances which are present in the different type of liquid, for example, blood, and also tumors in this blood we can find also specific mutations. So from tumor cells, from circulated tumor mutant DNA also is present in those liquids. So the potential markers which are important for the diagnostic and for personalized treatment are derived from exosomes and from circulated tumor DNA and RNA. So one marker is exosomes, so versus the cellular vesicle, which are normally present in physiological conditions in almost of cells, but those exosomes are also present in different type of tumors, which release specific markers which are very contain a lot of proteins, a lot of nucleic acids, lipids, and those markers are released in the different type of fluids, which can be used for the diagnostic. Circulating tumor cells are also present in the blood. However, the problem is that circulating tumor cells has a very short time of analysis, because due to the instability, the sample should be analyzed during 10-15 minutes, and therefore in currently diagnostic use is very limited of circulating tumor cells. However, circulating tumor DNA, which are derived from tumor cells and found in the circulation, are very, very potential important marker in the future, because the circulating tumor cells contain a lot of mutation which are present in tissue samples, and those also mutation, however, to a less extent and to a less concentration, are present also in different type of fluid, especially in the blood. And one of potential reason for circulating tumor DNA, 2 years ago, FDI approved specific testing from circulating tumor DNA. It has been found that in patients with lung cancer in the blood we can find EGFR mutation, and this EGFR mutation is in specific exon part of a marker of the lung cancer, not only as for diagnosis but also for personalized treatment. So in patients with advanced lung cancer we could have liquid biopsy and to obtain circulating DNA and to find out whether EGFR mutation is present or not. And this is one of the potential important of the treatment. During the last 2 years, after the FDI approval of the first test of EGFR testing, the extensive research has been made to discover whether it's true also for other type of tumors, whether we can find in the liquid biopsy the specific biomarkers. And one study which has been started last year aimed to evaluate by liquid biopsy of different type of prognostic biomarkers in different type of human malignancy: lymphoma, thyroid carcinoma, gastrointestinal cancer, bladder cancer, and prostate cancer. And now this research is currently ongoing, but the first results from the study which has been presented this year in the ASCO, American Society of Clinical Oncology Congress, are very promising, that it's possible to see different type of early changes in circulating tumor DNA in the blood samples, which could be useful for the early diagnostic of malignant tumor. So the study is aimed to be finished next year. We will have results, and it also could be changed for guidelines also for tumor diagnostic, especially for tumor with unknown primary, which is constitutes up to 5%, which we could not find the tumor location, but by these techniques it's possible to find out the tumor location. Of course, this liquid biopsy is very important in the disease monitoring, because when the treatment is started, so how we can assess whether the response is present or not. We start during the different time to retest the patient with non-invasive technique. Just take, for example, take a blood and to see whether this marker is present or not. And the recent studies which performed the correlative analysis of circulating tumor DNA with histology of tumor and with immunohistochemistry of tumor proved that those techniques and assessment correlate with tissue response, and with this method of circulated DNA assessment in lung cancer is acceptable and could be used in clinical practice, since it all correlates also with pathological tumor response in the tissue. And this liquid biopsy nowadays is also approved to be one of the potential important marker for the personalized treatment, since in the liquid biopsy we can assess the different type of gene mutation, for example, which is listed here in breast cancer, BRCA1 and 2, in different type of prostate cancer, the marker and ovary. It's also present in the liquid biopsy, and in such cases when the tissue biopsy is not possible to obtain, for such marker that have been currently validated to assess in the liquid biopsy. Of course, some genetical markers are still impossible to assess by liquid biopsy, and we still require the biopsy to perform not only standard histopathological assessment, but also to perform genetical testing, but nowadays promising results about some biomarkers which has now been validated and recommended in the use in clinical practice. Also in Latvia we have some progress which is made not only during the research, since in Latvia, in our University of Latvia, we have multiple teams which has research about tumor biology, and we also have done not only research in different type of tumor histopathology, but also in clinical practice and genetical testing. And our previous research found for lung cancer mutation panel diagnostic potential used in liquid biopsy, and also in our state in Latvia since this year April the liquid biopsy is reimbursed by the state, so patient with lung cancer could have liquid biopsy and it is tested. Nowadays it's possible only for lung cancer, but I think it's the methods is currently very perspective. It could be used also for different type of malignancy. However, we have our future, which is important, non-invasive diagnostic and digital assessment and artificial intelligence. However, I am fully sure that in any way still standard tissue assessment is very important. We could not move the diagnostic without it, but in many disease and in a different type of clinical conditions, still we could perform non-invasive diagnostic techniques like liquid biopsy, which for some tumor location have at least close the same diagnostic value as standard tissue histopathological attention. And I think the future is the combined modality and to use of different type of method, and of course multidisciplinary team, because without multidisciplinary team it is not possible to have success, not in the research, and also I think only in clinical practice. And with our conference, I guess also previous presentation highlight the value of this multidisciplinarity. Thank you very much for your attention.
Thank you very much for your really excellent presentation. I learned a lot of information nowadays. That's why my travel to Riga was successful. Do you think it's a place for surgery in 20-30 years? Because I think with the personalized medicine and when you go ahead in the research, I think in 100 years it's no surgery more.
Yes, thank you. So, as I have mentioned, of course we have, especially with the personalized treatment, some malignant tumor which 10-15 years ago we have very poor prognosis, and when surgery we could not fully remove the tumor. Now with progression with tumor diagnostic and personalized treatment, the prognosis for many tumors is very significantly improved. For example, patient with non-small cell and small cell lung cancer, prognosis in the advanced stage was very poor, but with introduction of this personalized treatment it was significantly improved. But still, of course, the surgery remains one of the gold standards for the tumor treatment, since by this treatment we can reduce the tumor volume, but still this surgical treatment is very important. But this treatment, especially before the surgery, could help to reduce the tumor volume, and when the surgeons could remove the tumor totally, because sometimes it's not so easy to do. So I think, and also very many colleagues, so we also in the future we will have both surgeon, we will have pathologist, we will have molecular genetic specialist, but it will just be the prognosis for the patients will be significantly improved, the implementation of multi different type of methods and the multifunctional team. So we will need in the future both pathologists and both surgeons.
Another question, this is only for a finance question. They are now over the world a leader company who are the best in genetics research, or is not still now? The landscape is unclear till now.
Yes, so for genetic research we have a lot of project that we have also now previously done and now implemented in the university about tumor genetic, about lung cancer project, and of course for the clinical use it should be collaboration between university and between.
I mean companies, private companies who are invest money in this kind of research for providing tests.
Yes, it's mainly also for basic research, also for clinical research. It's mostly a pharmacological company which is also invest the funding in such research in Latvia.
Probably any more questions for the audience, or was it already?
Okay, if no question.
Actually, I had not questions, but I would like to express deeply gratitude. Thanks a lot for our guest, Dr. Adali, and thanks a lot to my university team, academic team. Today we had best of us here, and thank you to participants and our technical staff. Thanks a lot. I think that we today had very nice time, very useful time, and nice possibility to think about. Thanks a lot.
Dear colleagues, I also would like to thank all lecturers and all participants, also those who are online with us. We have good conferences, and I think we will also continue with such format in the future, and also to have collaboration with our partners. So thank you very much for your attention.